السلام عليكم.
وعليكم السلام.
وعليكم السلام.
وعليكم السلام ورحمة الله وبركاته.
وعليكم السلام.
How are you guys?
Fine, sir.
الحمد لله.
Good,
How are you,
doctor.
sir?
How are you?
الحمد لله.
Okay, fine. Today, inshallah, we'll continue some station for resuscitation, ATLS. For new members who joined today or yesterday, we have two stations in the exam, resus. It could be newborn or ABLS. It could be ALS. It could be ATLS. Inshallah, today we'll finish all ATLS stations if you help me. And next session, our schedule, as usual, it will be Saturday, Monday, Wednesday, as usual. It will be. When is the next session, guys? What do you think?
Saturday.
Okay, so the next session will be practical skills and teaching.
Saturday.
So we will do teaching ECG, teaching ABG, and then nerve blocks. Then we will go for procedures. So we will start by teaching ECGs, ABGs, also X-rays, and then nerve blocks. Then we will go for procedures. It will take 2 to 3 sessions. Injured patient, 1 session for joint, 1 session for system. Communication skills, 2 to 3 sessions. Regarding Chennai face-to-face course, we still have a few seats. Regarding Malaysia, also we still have few seats. You have 5 domains to get 10 out of 10. Accuracy, skillfulness, efficiency, structure, supportiveness, safety. Accuracy, it means you should mention all the points in the general approach. And the skillfulness, you should be fluent. Regarding efficiency structure, you should be organized. Supportiveness, your voice should be loud and fast. If you cannot control your voice, no problem, don't worry. I mean, if this will make you stress, don't be fast. You can be normal, no problem. Safety, correct information. For ATLS today, we will practice first one, head and maxillofacial, omnia.
Yes.
This is your station, head and maxillofacial injury, okay?
Okay.
Brogna,
So,
same. Your station, head and maxillofacial injury. So you will find the patient has raised intracranial pressure and, of course, indeed, disability. So maybe the patient has hypertension or maybe hypotension. So I will make for Omni hypertension and for Brogna hypotension. Of course, I will give you ideas, okay?
Okay.
yes, sir.
Flail chest and tension pneumothorax, Rosamond.
Yes.
This is
Yes.
your station, flail chest and tension pneumothorax. For sure, the patient has a paradoxical chest rise in inspection and abrasion contusions. The patient has segment
Second.
go up, chest to go down, other way around, this segment go down, the chest to go up. Clear?
Yeah.
So when the examiner say paradoxical chest rise, you will understand the diagnosis is flail chest, okay? Tension pneumothorax, the examiner will say deviated trachea, hyperresonance, and blah, blah, blah. Clear?
Yes.
Okay, of course, I will give you idea as well. The next station, Azam,
Yes, Dr. Hamid.
how are you?
I'm fine. How are you?
Yes. Open pneumothorax and tension pneumothorax. So open pneumothorax, it means open means penetrating wound. Clear?
Yes.
Penetrating wound. And this wound should be sucking. Okay. So if the wound is not penetrating, it's not open. If the wound is not sucking, it's not open. Clear? Okay. Plus tension pneumothorax, it means deviated trachea, hyperresonance, and blah, blah, blah. So you can find flail chest with or without tension pneumothorax. You can find open pneumothorax with or without tension pneumothorax. Clear, Azam?
Yeah, clear.
Okay. For next one, Nikesh? Nikesha?
Yes, Dr. Honey.
Um, what is your good name?
Nikisha.
Okay. So here regarding massive hemothorax. So of course you will find deviated trachea and stony dullness. Clear, Nikesha?
Yes.
Okay. Next one, Abbas.
Yes, sir.
So your station abdomen blunt injury. Abdomen blunt injury. So here we should talk about emergency laparotomies. You should be familiar with indications of emergency laparotomy. Okay?
Yes, sir.
It is
Yes, please.
your station will be abdomen penetrating injury. Same. So your task will be in the circulation. Clear?
All right.
Abdomen penetrating injury. Okay. The next station, Sondas.
Yes, sir.
Your station is pelvic fracture.
Okay.
So your task in C in circulation. So everyone will catch the problem in one system. And you have non-pharmacological and then pharmacological. If you don't have non-pharmacological, jump to pharmacological. But if you have non-pharmacological, for example, pelvic binder, this is non-pharmacological. So you should start by non-pharmacological. Clear, doctor?
Yes. Yes,
And
sir.
so on. Of course, I will give you IDA later.
Okay.
Ike,
Yes, sir.
bilateral lower limbs amputation. So the patient, of course, the problem in C, circulation. So your task is massive transfusion protocol. So you should stop major hemorrhage. So your approach, not ABCDE, no, C ABCDE. Clear, Ike?
Yes, sir.
C, A, B, C, D, E. C first before airway. So you will ask the nurse control any major bleeding. The patient has bilateral lower limbs amputation, so direct compression with dressings, and then go for airway. Okay. Major burn. Who is happy to do major burn? Of course, I will give idea also.
I can try.
Okay.
Okay, later we will see.
I can do also, Dr. Han.
Okay, Sondas. Later, I will give you idea, of course. Before any station, before any station, I will give idea for everyone. You will be professional. But I want to give you some hints very quickly. So, head and maxillofacial injury. You will find hypotension, facial chest tension pneumothorax, hypotension, any station, hypotension. What is the cause of hypotension? It could be something relevant to the brain only. It could be something relevant to the chest only. It could be something relevant to the circulation. I mean, hemorrhagic. Okay. So, head and maxillofacial injury. Why the patient has hypotension here, guys?
Great question, Faraj.
Increase
Raise your,
intracranial pressure.
raise your
Increase
voice.
intracranial pressure.
Raised intracranial pressure.
Raised
Great
intracranial
intracranial.
pressure. Excellent. Do you think the patient has hemorrhagic shock?
No.
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 The patient has 5 letters. Massive blood loss, it means loss of more than 2 letters. Okay. Do you think he will lose more than 2 letters in his head? The head is very small, right? The head full of brain. No space for the blood loss, right?
Yeah.
Okay. But chest, it could be hemorrhagic, yes. The chest can accommodate, for example, more than 2 letters, yes. The chest can accommodate more than 2 letters, yes. Okay. The abdomen can accommodate more than 2 letters, yes. Even up to 5 letters. The patient can lose 5 letters in his bowel or in his abdomen. It will be distension. In limbs, yes, each limb can accommodate more than 750. The lower limbs can accommodate, every lower limb can accommodate more than 1.5 liters. Can you imagine? Very serious, very dangerous. Okay, so the most important to understand what is the cause of shock. When you reach hypotension in any station, whatever ALS or ABLS or ATLS, you should mention the type of shock. So here in head and maxillofacial injury, you have 2 stages. If the patient has unequal pupil plus minus seizures plus minus hemiplegia or hemiparesis, he cannot move the right side or left side, or maybe weakness. He can move but with weakness. The patient has bradycardia. The patient has hypotension. This is late stage. Why? Because the first stage is systolic hypertension. So if you find the patient with systolic hypertension, you should be happy, still in the first stage. Then the patient cannot compensate anymore. You will find hypotension. Any patient with hypotension, it means late stage. Any patient, any patient. Allah created us with compensation. Okay, so we have compensatory mechanisms. Any problem will happen, it will take whatever few minutes, a few hours, compensation. Then the body will fail compensating. Okay, so for example, patient has respiratory problem, for example, bronchial asthma. Which is the first stage? Hyperventilation or hypoventilation?
Hyper.
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 Hyperventilation.
So the first stage is compensation. Okay, the body is trying to hyperventilate to put oxygen more inside the chest and push CO2 more outside the body. This could be for few minutes, could be for few hours, could be for few days, yes, like COPD. Could be for few months, yes, like COPD. But cannot compensate anymore. You will find the patient has hypoventilation later. So any hypo, whatever hypoventilation, whatever bradypnea, whatever the patient has hypotension. So any hypo, this is late stage. So if you find hyper, this is first stage. Okay. So here in head and maxillofacial injury, once you find the patient has bradycardia, unequal pupil, systolic hypertension, then you should manage the patient and you should mention in circulation the patient has signs of raised intracranial pressure and this could be the cause of shock. You should mention that. Okay, then if hypertension, give mannitol. If hypotension, give Hypertonic saline. And of course, a non-pharmacological treatment, it means there is the head of bed, intubation, controlled ventilation, call anesthetist to intubate the patient, then connected to back valve mask, one ventilation every 60 seconds, and blah, blah, blah. As we mentioned earlier in pediatric and in ALS as well. Regarding flail chest and tension pneumothorax, if you find the patient has flail chest only, it means paradoxical chest rise only. So you will give pain management only. So what is the treatment for flail chest, guys?
Intercostal block.
Intercostal nerve block.
Pain management. I did not say intercostal now. I said pain
Pain
management.
management, yeah.
Pain management, 3 points.
Ketamine.
3 points. So number 1, intercostal nerve block now. Why now? Because no need for IV access. You will do intercostal nerve block for 2 reasons. You don't need IV access and you don't need IV morphine at the moment. Okay, so intercostal nerve block helpful for relieve the pain of the fractured ribs and also anesthetize or numb the area to insert needle to compression or chest drain. Okay, tension pneumothorax, of course, you will do needle decompression plus chest drain. Okay, so flat chest, you have 3 points. Number 1, intercostal nerve block and IV morphine or IV ketamine. Then you will give the patient thoracic epidural. This by anesthetist. Okay. Open pneumothorax. It could be open pneumothorax only. Yes. What is the treatment for open pneumothorax?
UA occlusive dressing.
3-sided occlusive dressing. Yes. And what is the treatment for tension pneumothorax?
Needed decompression.
Need
Chest drain.
Yes, tension pneumothorax only without open pneumothorax. You will do needle decompression plus chest drain. But open pneumothorax already you have open, right? Do you need needle decompression?
No.
No. Needle decompression, you are using a needle, whatever 16 or 18, to make opening in the chest. So you are making like 2 mm or 3 mm. But open pneumothorax, you have like 3 centimeter. Which is better, the open pneumothorax or the needle decompression?
Open pneumothorax.
Open pneumothorax, excellent. So don't say needle decompression, not logic here. Okay. So massive hemothorax, the treatment is chest drain. Okay. Abdomen blunt injury, the treatment is blood transfusion. So what is the cause of hypotension in flat chest and tension pneumothorax?
Flail chest is
Obstructive shock.
obstructive hypovolemia.
Hemorrhagic.
Not logic to say obstructive hypovolemia. How? You have obstructive, you have hypovolemia. This is different than this.
Hypovolemia.
Obstructive shock, not hypovolemia.
Obstructive hypovolemia.
Obstructive, don't say hypovolemia. Please listen to me, doctor. I said, don't say obstructive hypovolemia. Nothing is called obstructive hypovolemia. Don't invent. Clear? So, the cause of tension pneumothorax, obstructive shock. What does it mean, obstructive shock? The air, pneumothorax, the air inside one lung, in the pleura, cause compression on the lung, then cause compression on the heart. Can you imagine? And this compression obstructing the fluid, obstructing the blood to go to the heart. That's why the patient has hypotension. So obstruction. Obstructing what? Obstructing blood to go to the heart. Do you think we will give the patient fluids to increase the obstruction?
No.
Is it logic? The heart has compression from outside. Do you think you will do more compression from inside? No. So any patient with tension pneumothorax, the problem is breathing or circulation.
Breathing.
Breathing.
Breathing. Flail chest and tension pneumothorax, the problem is breathing. Okay. Head and maxillofacial injury, the problem is
D.
Disab-
disability. Okay. So flail chest and tension pneumothorax, the problem is breathing. Do I need to go to circulation?
No.
No. Someone will say, I want to go to circulation to confirm he has hypotension. I don't care. If the patient has no hypotension, it's not tension pneumothorax, no. Patient has hyperresonance. Patient has deviated trachea. Okay. This patient needs needle to compression plus chest drain. I don't care about hypotension. Okay. So, do you need to give fluids? No, contraindicated. Don't give fluids for tension pneumothorax because the blood volume is normal. If you will give the patient has already 5 liters blood, normal, 5 liters. Why you are giving the fluids more? Why you are making more obstruction? Not logic. Okay. So breathing, stop in breathing. Manage the breathing. Okay. Open pneumothorax and tension pneumothorax. What is the cause of shock?
No. Open thoracic tension.
Obstructive shock.
Hypotension.
Obstructive shock. Why you are thinking? Tension pneumothorax, same. Any tension pneumothorax, obstructive. Okay. So again, air compressing the lungs, compressing the heart. So obstruction. So the atrium and the ventricle pressure. So no space in the ventricles. So do you think you will give more fluids?
No.
No. Serious, dangerous. If any doctor in real practice doing that, he is not knowledgeable. Take care. Okay. Massive hemothorax. Massive hemothorax. What is the cause of shock?
Hypovolemic.
Hemorrhagic hypovolemic.
Hypovolemic hemorrhagic. Hypovolemic hemorrhagic. So the patient lost blood internal or external?
Internal.
Internal, inside the body. Where? In the chest. Where? In the pleura. So same as pneumothorax. In pneumothorax, the patient has air in the pleura. This air make pressure on the lungs, make pressure on the heart. The bleeding in massive hemothorax, the patient is losing blood from arteries in the lungs, in the pleura. This blood is massive. This blood make pressure on the lungs, make pressure on the heart. Clear? Make pressure on the heart. So, which is priority, breathing or circulation?
Circulation.
What is the problem in massive hemothorax, breathing or circulation?
Breathing first.
Circulation.
The
Both.
patient lost the blood in the chest or lost the blood in the abdomen?
Breathing.
Chest.
Breathing. The problem is breathing. Patient has massive thorax, breathing. Okay. What is the problem, breathing or circulation?
Breathing.
Breathing. Okay. So did we say massive hemoabdomen? We said massive thorax. So the patient has two problems now. Problem blood loss and the problem massive hemothorax. It means pressure on the lungs, pressure on the heart. Clear? So which is priority? You will give the patient more blood to make pressure on the heart. The patient has pressure from the blood inside the chest, pressure on the heart, and you want to give more blood to make pressure on the heart, or you will release the pressure on the heart from outside, then give blood. Which is better?
Release pressure from outside.
Release pressure from outside, then give blood to restore the blood volume. Easy. If you will give the patient blood without releasing the pressure from outside, the patient will die. So which is priority, breathing or circulation?
Breathing.
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 Breathing is the priority. Okay. So I want to go to circulation to check if the patient has hypotension. What do you mean by hypotension? Already the patient has massive hemothorax. The patient has deviated trachea. The patient has a stony dullness. Stony. I did not say dullness. No, I said stony dullness. Something heavy, something massive. Massive blood loss, it means the patient lost more than 2 liters. If the examiner said stony dullness, it means the patient lost more than 2 liters. Do I need to confirm that by circulation?
No.
If the patient, what are the criteria for massive blood loss? Number one,
Respiratory rate more than 30. Heart rate
excellent.
more than
RR more than
110.
30. Huh? And the heart rate more
Heart
than
rate more than 110.
110. Okay. And the systolic blood pressure less than
90.
90. But if you don't have massive hemothorax, okay. But if you find in breathing, the saturation is 50 or 80, and the RR is 40 or 50, and the patient has a stony dullness and the trachea deviated, this patient lost more than 2 liters. Easy, guys?
Yes, sir.
Okay. So the management, chest drain, and then go for circulation and give the patient massive transfusion. Okay. Abdomen blunt injury. What is the cause of shock?
Hemorrhage.
Hemorrhagic.
Hemorrhagic.
Hypovolemic hemorrhage.
Hypovolemic hemorrhagic shock. Okay. So what is the treatment? Blood transfusion and then surgery. Okay. Penetrating, say, blood transfusion and then surgery. Pelvic fracture, so pelvic binder. So massive hemothorax and then abdomen blunt injury until major burn. What is the cause of shock? Hypovolemic hemorrhagic shock until proven otherwise. Clear, guys?
Yes, sir.
So any trauma, hypovolemic hemorrhagic shock, except head maxillofacial injury, the cause is raised intracranial pressure until proven otherwise. Flail chest and detention pneumothorax, the cause is obstructive. Open pneumothorax and detention pneumothorax, the cause is obstructive. Okay, we will do some practice. So the same here. Introduction and handover from ambulance crew. So introduction briefing, the team assign roles and prepare equipment, and handover from ambulance crew and or relatives or the patient if the patient is conscious. ABCDE, full assessment, full finding, full call, full intervention, hand over to relevant specialty, then reassess the patient will be brief. Here regarding the ATLS, the airway is different. So once you go inside the room, you will be behind the head and introduce yourself. So behind the head, just say manual inline stabilizer, just verbalize. And your hand, one hand close to the ear and the other hand close to the other ear. Okay. No need to hold the mannequin. No need to do kneeling. No need. Try to be straight, no problem. And just put two hands like that, parallel to the ears. Okay, so just verbalize manual inline stabilization and ask the same questions. Is the patient conscious? If yes, apply cervical collar and high flow oxygen. If no, clear airway, oropharyngeal. Don't say nasopharyngeal in trauma. So clear airway, oropharyngeal, apply cervical collar and high flow oxygen. Then go for breathing as usual. Expose the chest and connect all monitors. Ask about the 8 points one shot. What about SpO2, RR, trachea, veins, inspection, palpation, percussion, auscultation of lungs and heart. Then circulation, how many points in circulation?
9 point.
9.
9 points. So in ATLS, 9 points. So you will ask one shot? Yes, no problem. What about blood pressure, CRT, peripheral pulses, and heart rate? What about abdomen inspection, palpation? What about pelvis stable? What about long bones, any deformity? What about fast, any free fluid collection in 4 views. So if the examiner said inspection palpation, he said, for example, abrasion in the right upper quadrant. Then when you ask about fast, you can say, what about fast? Any free fluid collection in the right upper quadrant and the other views? This is the correct question. You are showing the examiner you care about this area. Why? Because he has abrasion contusions here. If he said, for example, the patient has abrasion contusions in the pelvic area, then you can say, what about fast? Any free fluid collection in the pelvic area and other views like that. Okay. Disability will ask about 4 points. One shot. What about GCS? Any signs of lateralization? What about pupils equireactive? What about blood sugar? And in exposure, expose all the body. Any other abnormalities? What about temperature? Regarding log roll, it's not important. If you want to mention, okay. If you don't want to mention, it's not a big issue. The most important here, the ABCDE approach. Okay. So regarding the massive transfusion protocol, so you can start in the first circulation. Okay. You can start 4 units, same blood group. It means a cross match. If not available, you can start O blood group. If male, O positive. If female, O negative. If female but postmenopausal, O positive. So same blood group, 4 units. O blood group, 2 units. So you whatever same blood group or O blood group should be bagged RBCs. In the next circulation, you ask about any blood results. If the blood results available, correct the abnormalities. If the blood results not available, then give full primary pack. So correct abnormalities, it means if hemoglobin is less than 8, give 4 units backed RBCs. If INR more than 1.2, give 4 units fresh frozen plasma. If platelets less than 50,000, give 1 unit platelets. Then next circulation, ask about blood results again. If blood results available, correct the abnormalities. If not available, you will give secondary pack. It means 4 units backed RBCs, 4 units fresh frozen plasma, 1 unit platelet, and then 2 units cryoprecipitate. Okay. So at any time the examiner will ask you the blood pressure is still low, then ask any blood results, then correct the abnormalities or give the secondary pack. So here regarding the second circulation, I want you in the first assessment, finish A, B, C, D, E. In the second assessment, finish A, B, C, and stop in C. Okay? Because the problem in C, don't jump to second D. No need. I want you to stop in the second C. Clear, guys, this point?
Yes, sir.
Okay. If the patient has problem in disability, so you will finish A, B, C, D, E, hand over, then A, B, C, D, E, and stop in D, second D, because the problem in D, and so on. Okay. We will go for Omnia and Brovna.
Yes, sir.
So your station, the patient has systolic hypertension. The patient has maybe distorted facial anatomy. It means the nose is cut, the lips cut. The patient has bleeding everywhere in his face, bleeding from ears. So this patient has facial injuries. So what to do here? You will do suction or continuous suctioning.
Suction on
Continuous
oropharyngeal.
suctioning. Do you think when you
Okay.
do suction, the bleeding will stop?
No.
No. So keep suctioning, okay, until no more bleeding. Easy? Okay. So if you will say clear airway and then oropharyngeal airway and then apply cervical collar high flux, more than enough. Okay. But I'm explaining. So here you will call the trauma team, including anesthetist. This patient needs the intubation. Easy?
Okay.
So you will keep the patient on high flow oxygen until they will intubate. If you want to intubate from the start, it's up to you. Do you think this patient doesn't need intubation? No. Any patient with distorted facial anatomy, intubation, number one. Clear? Okay. So you have suspected compromised airway. This patient needs intubation. Okay. Then when you go to circulation, you will find the patient has systolic hypertension, bradycardia, and in breathing RR10. If RR10, you will apply back valve mask in breathing, right?
Yes.
One ventilation every
6 seconds.
60 seconds. Okay. In circulation, the patient has systolic hypertension. No need for any intervention, just insert two IV access and blah, blah, blah. In disability, you'll find the GCS9, but the patient has raised intracranial pressure and blah, blah, blah. So Cushing triad here. This patient has raised intracranial pressure, then you will do non-pharmacological and then pharmacological. Clear?
Yes.
So it's up to you. You want to intubate the patient in airway, accept it. You want to intubate the patient, but if you will intubate the patient in airway to protect the airway, if you will intubate the patient in disability, not to protect the airway, for controlled ventilation. Clear?
Okay.
So if you will control ventilation, for what? To control the PaCO2, the BaO2, and blah, blah, blah. So you will decrease the intracranial pressure. Clear?
Okay.
Okay. Anyway, if you will intubate in A or intubate in D, uh, you should connect to back valve mask, one ventilation every 6 seconds, and then check the 4 points of success. Bilateral auscultation, bilateral chest rise, and also ATCO2 and SpO2. Clear, doctor?
Yeah.
In intubation, you will say raise the head of bed, raise the head of bed. What else? You will make the cervical collar loose. You will make the AT tube tie loose, and then start the pharmacological treatment in disability. I wish it's clear.
Okay. Okay.
If the patient has heart rate 55, any hemorrhagic blood loss,
No.
he want to
No,
say
sir.
hemorrhagic blood loss if heart rate more than
110.
110.
110. Easy.
Yes, sir.
If RR more than
30.
30. I wish it's clear. Okay, you have 30 seconds and 6 minutes.
Okay, can I start? Hello, my name is Victor Omni, Emergency Medicine Registrar. Can I confirm your name and level? Are you ATLS provider? We are expecting patient with head injury and facial injuries. Is the patient alive? Please prepare airway and circulation equipment. Okay. Any handover from the ambulance?
Yes, this patient, he has a head injury, road traffic accident.
Okay. Is the patient conscious?
The patient is unconscious.
Look, listen, and feel any signs of life?
Yes.
Is the airway patent?
The patient has bleeding and vomiting in mouth. I cannot see the nose or lips. The patient has much bleeding from
Alright.
nose, mouth, and ears.
Or please suction airway, apply oropharyngeal and keep suctioning. Also connect patient to oxygen. Bless cervical collar. Expose the chest of the patient. What about respiratory rate, SpO2, trachea and neck veins? Inspection, palpation, auscultation of lung and heart, any abnormalities?
The patient has SpO2 is 80, RR is 4, and poor respiratory effort.
Okay, connect patient to back valve mask and oxygen and give braces every 6 seconds. Moving to circulation, what about the heart rate, blood pressure, CRT and peripheral pulses? Okay, in abdomen, in inspection and palpation, any abnormalities? Is pelvis stable? Any long bone deformities? In fast scan, 4 areas include collection.
The heart rate, this one, and the inspection palpation normal, and regarding the pelvis is normal, long bones are normal, fast is negative.
Okay, insert 2 pore cannulae, extrapolate for hematology biochemistry, blood gases. Okay, moving to disability. What is the GCS of the patient?
GCS is 9.
Pupils, equal and reactive.
Pupils unequal, dilated right side.
Okay, any signs of lateralization?
The patient has hemiplegia, right side.
What is the random of the patient? And the blood glucose?
Blood sugar is 5 millimole.
Okay, from these findings, as the patient is bradypneic, bradycardic, and has systolic hypertension and the history of head injury, this patient most probably has pushing triad due to increased intracranial pressure. Please call trauma team, neurosurgery team, ICU team, and we need anesthetist because this patient needs intubation and controlled ventilation to decrease his ICP. Please intubate the patient, insert in the tracheal tube, connect patient to back valve mask on oxygen. The 4 areas is the chest rising.
Yes.
On auscultation, equal air entry.
Yes.
What about the end-tidal CO2?
Improving now.
Okay, give braces every 6 seconds via ET tube and connected to back valve mask and oxygen supply. Elevate bed to 30 degree and lose the cervical collar. Please also give this patient monitor 1 gram per kg over 15 minutes. Okay. Expose the patient. Any other abnormalities? What is the temperature of the patient?
Normal.
Normal. Okay. Insert urinary catheter and connect it to urine bag. We will need to do CT scan of the head after patient is stable. Is the neurosurgery and trauma team available now? Okay, we will assess our patient. What about the respiratory rate and SpO2?
Improving.
What about heart rate and blood pressure?
Heart rate is improving now.
Okay, and pupils?
Improving.
The signs of lateralization?
Improving.
Okay, so well done team. The patient is improving, blood pressure is rising, and his oxygenation rising. Any lab results?
What do you need?
I need the ABG, the pH, and the BaO2 and the BaCO2.
The pH is 7.1 and the BaO2 is 5 and the BaCO2 is 9 and the bicarb is 10.
Okay, this
Lactate is
patient has,
3.
all right, this patient has type 2 respiratory failure as he is retaining and has low oxygen. Please increase the ventilation of the patient. Give breaths every 5 seconds. All right. Now, what about the heart rate and blood pressure? The signs of lateralization pupils improving. Back again to the respiratory rate and saturation. Are they improving? Can we hand over the patient to trauma team and neurosurgery team? Because the patient needs emergency craniotomy to evacuate the bleeding and also need to be admitted to the ICU for further management and observation.
Okay, thank you. Thank you, Omnia. Your time done already. Okay. Well done. I think you covered almost all the points. Did you give mannitol?
Yes, 1 gram per kg.
Yes. So mannitol, 1 gram per kilogram. So here you are perfect, perfect, perfect. You have only one missed point.
Okay.
What is it?
Um, full findings.
Yes. So if the patient has normal points, mention normal. If the patient, for example, I show you monitor of sinus rhythm. For example, you can say sinus rhythm. Easy. If I show you sinus tachycardia, mention sinus tachycardia. If I say heart rate is 55, so you can say the patient has bradycardia. Clear?
Yeah. I
You
think
have
I told
problem
the
in
patient.
findings. You ask me in
I
breathing, I said SpO2 is low, RR is low, and the patient has poor respiratory effort. You ignored that. You did not repeat the finding. Did you get my point?
yes.
So you have problem in findings. So findings here, you should show the examiner that you quote the findings. Okay?
Okay.
So you can say the patient has hypoxia, bradypnea, poor respiratory effort. It could be because
Oh, increase intracranial pressure.
no, we have no
Oh,
evidence now for resident
okay,
ground pressure. You can say because of head injury.
because of head injury.
We have evidence the patient has head injury from the scenario.
Yes.
I did not reach circulation or disability to say resident ground pressure. Don't
Oh,
mention anything without evidence. Clear?
clear.
To avoid misconduct. So you can say the patient has, repeat what I said. The patient has hypoxia, bradypnea, poor respiratory effort, could be because of
Head injury.
head injury. Then give the patient back valve mask, one ventilation every 60 seconds. Clear now? Okay.
Oh,
Then call.
okay.
Then call. So don't ask for back valve mask now. Just verbalize the findings. So you can say the patient has bradypnea, hypoxia, poor respiratory effort. It could be because of head injury. Call trauma team and the neurosurgeon, including anesthetist and the neurosurgeon. Easy?
Easy.
Then full intervention, what you will do, back valve mask, one ventilation every 6 seconds, and they prepare difficult airway trolley for intubation. Easy?
Okay.
Done. Then you will go for second assessment. In second assessment, what is the problem? Disability. Any problem in breathing?
Yes. Patient is
No,
has low
no problem in
respiratory.
breathing. The patient has
Oh,
symptoms of breathing, but no problem in breathing. There is difference between the cause and the symptoms. Did you get my point?
yes. I get it.
The problem is head injury, not chest injury. So any problem in breathing? No.
No.
He has bradypnea, he has hypoxia, but no problem in breathing. Did you get my point?
Yes.
So do you need to do chest imaging? No. Clear
No.
now? If
Clear.
the patient has no head injury, but he has hypoxia and bradypnea, yes, you can do chest imaging. I wish it's clear.
Okay. Clear.
So you have reasonable explanation for breathing symptoms, no need for chest imaging. But you can ask about blood gases in second breathing. Okay? You can,
Okay.
yes, you did well. You can do CT scan after stabilization. What does it mean, stabilization? This patient is stable or unstable? Systolic blood pressure is 100, for example, 50 over 80. Stable or unstable?
Stable.
No, unstable. Okay. Patient has resident intracranial pressure stable? No. Patient
Unstable.
has
Okay.
unequal pupil stable? No.
No.
Patient has hemiplegia stable? No. Patient has um, signs of lateralization. Maybe he has seizures also. Stable? No. So
Stable.
stable here doesn't mean blood pressure. Stable it means A, B, C, D, E, right?
Okay.
Can I move the patient to CT scan without Stabilizing the airway? No. Can I move the patient to CT scan without stabilizing the breathing? No. Can I move the patient without stabilizing the circulation? No. If airway, breathing, circulation normal, can I move the patient without stabilizing the disability?
No.
No. So I cannot move the patient with unstable disability. What does it mean? Hemiplegia and the patient has unequal pupil. It means something making pressure on the brain. I am happy with the blood pressure. No, blood pressure is not my issue now. There's something making pressure on the brain. Every minute make brain death. Did you get my point?
Yes.
So the blood pressure is normal. I'm happy and I'm moving the patient without mannitol, moving the patient without controlled ventilation, or moving the patient without hypertonic saline, okay, if hypotension, and moving to CT scan to confirm the problem. Why I will confirm the problem? I know the problem without imaging. So the priority is treatment. The problem is pressure on the brain. The brain will die, okay? I don't care about the blood pressure now. Clear, doctor? So once the blood pressure improve, how to know the blood pressure is improving? The patient has systolic hypertension. It means, for example, 170 over 80. So if the systolic blood pressure decrease to normal, it means this patient stabilized. If the pupil became normal, equal, it means stabilized. Patient has before hemiplegia. If I am benching him, if is just is 9, I am benching the patient, moving one side only, the other side. Okay. Then this patient has hemiplegia. After mannitol, after controlled ventilation, I found the patient is moving both sides and the pupils equal. If he has seizures before, no more seizures. After I give him mannitol, after I controlled the intracranial pressure, he has no more lateralizing signs like pupil, seizures, hemiplegia. Clear, doctor?
Clear.
So stabilization of the patient here, it means stabilization of the intracranial pressure. Clear now? Then I will move to the CT scan. You ask me, I said improving. What about pupil? Improving. What about blah, blah, blah? Improving. It means the patient intracranial pressure normalized. You should mention that. So I want you to care about findings. Clear, Omni?
Okay, clear.
Something bad, mention. Something improving, mention. You can say, excellent, guys, the pupil became equal. Excellent, guys, the systolic blood pressure became normal. Excellent, guys, no more signs of lateralization. It means the intracranial pressure is decreasing. Good. Show the examiner you understand what is going on. If something going bad, mention. Something going normal or good, mention. I wish it's clear.
Clear.
So you have problem in
Findings.
and call. Then do intervention. I wish it's clear. I will give you 8 out of 10. Thank you. So this
Okay.
patient needs neurosurgeon for what? For to remove the bleeding. Okay? Even
Okay.
the intracranial pressure improved? Yes. Your target to improve the intracranial pressure before the surgery. So no risk from the surgery. So you should say it could be hemorrhage inside the brain. This patient prepare the theater. Prepare the theater. So you will activate massive transfusion protocol. You don't need, but massive transfusion protocol for what? For the surgery, not for the hypotension or any problem in blood pressure. Did you get my point?
Yes.
So any patient will do surgery, you need blood transfusion. So the blood transfusion for the surgery, not for the massive blood loss. The patient has no massive blood loss. Excellent, thank you.
Okay, thank you.
Brogna?
Yes, sir.
So you will do this station, but this time the systolic blood pressure low. It means late stage. Clear?
Clear, sir.
Okay.
Hello, I am Dr. Broka, emergency registrar here. May I know your name and label, please? We are expecting a patient with head and facial injury. Are you comfortable with airway management? Please prepare airway equipment and circulation equipment. Is the patient arrived? Any handover from ambulance crew?
Yes, this patient has road traffic accident. He has head injury.
Okay, so now I am doing manual inline stabilization. And what about consciousness level of the patient?
The patient is unconscious.
Any sign of life? Look, listen, feel.
Yes.
Okay, what about airway? Is it patent?
Not patent. The patient has bleeding, vomiting in mouth. He has distorted facial anatomy. No mouth, no nose. I cannot see the nose or lips. The patient has bleeding from nose, mouth, and ears.
Okay, so patient has bleeding from mouth, nose, and face, and has distorted face. Please call anesthesiologist and trauma team. Patient may need intubation and clear the airway, apply oropharyngeal airway, and give high flow oxygen, and apply cervical collar. Now chest connect all chest monitor, and what is the respiratory rate, saturation, neck, vein, trachea, inspection, palpation, percussion, auscultation of the heart and lung.
The patient has hypoxia, bradypnea, poor respiratory effort. Otherwise, everything is normal.
Okay, patient has hypoxia, bradypnea with poor respiratory effort. We already called a trauma team, and including anesthesiologist. And now please give high flow oxygen with back valve mask, one ventilation over 6 seconds. Now, what about the blood pressure, CRT, heart rate, and peripheral pulse? What about abdominal inspection, palpation, and pelvis stable or not? Is any deformity in the long bone, or in the first scan? Is there any free fluid in foreview?
The patient has heart rate this one, and abdomen inspection palpation normal. The blood pressure is 80/30. The CRT is 7. Pelvis is stable. Long bones are normal.
Okay, so here a patient has bradycardia with low blood pressure, hypotension, with low hypotension with febrile peripheral pulse, otherwise is normal. So please it is this hypotension and bradycardia may be due to head injury. So please call neurosurgeon and prepare operation theater, and do 2 IV bore cannula and extract blood from hematology, biochemistry, toxicology, blood gases, blood culture, and blood cross matching, and blood grouping, and give 250 ml normal saline over 10 minutes. Now move to the disability. What is the GCS? Any lateralizing sign present? What about the pupil, and what about the blood glucose?
The blood sugar normal. The patient GCS is 9, and the pupils unequal, dilated on the right side. The patient has hemiplegia.
So here patient has GCS, low GCS with hemiplegia with unequal pupil, which is dilated in the right side, and patient has normal glucose level. So patient also has bradypnea, bradycardia, and hypotension, and it is indicate increased intracranial pressure because of bleeding inside the head. It causes compression over the brain and respiratory center and cardiovascular center. So please call, already we call neurosurgeon and prepare operation theater, and call and activate massive blood transfusion for operation, and call anesthesiologist for intubation. Patient need intubation early. emergency intubation. Intubation done. Tube connect with back valve mask and one ventilation over 6 seconds. And please check saturation, EtCO2, bilateral chest movement, and bilateral chest auscultation.
Improving.
Okay, so a tube is in, and we do CT scan after patient stabilize. And for see bleeding, we will already have patient has intracranial pressure rest sign symptom. Now expose all the body and see any other abnormality and for temperature. Okay, so now I want to hand over this patient to the neurosurgeon and trauma team. And are they arrived? Okay, so I am reassessing the patient. Patient is already intubated. What about the respiratory rate and the saturation?
Improving.
Okay, any blood gas result?
What do you need?
PA, partial pressure of oxygen, partial pressure of carbon dioxide, is bicarbonate and lactate.
pH is 7.2 and the BaO2 is 5 and the BaCO2 is 9 and the bicarb is 10 and lactate is 3.
So it is mixed acidosis with type 2 respiratory failure. And patient, please maintain hypoxemia and hypocapnia. Normocapnia and normoxemia. Please increase respiratory rate by one ventilation over 5 seconds. And what about the blood pressure? What about the heart rate?
Improving now. Thank you, doctor. Thank you.
Thank you.
Okay, well done. Excellent, Brogna. So you are doing a full assessment, full findings, full call, full intervention. Excellent. So you are explaining everything, each point you are doing. So I think you covered almost all the points. Here regarding airway, you did breathing, circulation, and disability exposure. The patient in disability, did you give hypertonic saline?
I forgot that. I
Okay.
don't.
So you should give hypertonic saline. I considered you give already, but this will affect the safety, okay? So hypertonic saline, mannitol, 1 gram per kilogram over 15 minutes. In hypertonic saline, in adult, you will give 500 cc, 3% hypertonic saline. Okay. So this will remove the fluids, remove the water from the brain. It will release the edema. It will decrease the intracranial pressure. Okay. And it will improve blood pressure also. In pediatric, you will give 10 ml per kilogram according to weight flag over 15 minutes or over 30 minutes. Okay. I will give you 8 out of 10, okay?
Thank you.
Because you missed the point of hypertonic saline. This is the main problem, the main treatment, but not the definitive treatment. The definitive is surgery. Clear? You mentioned already surgery. So even if you forget hypertonic saline, you did controlled ventilation. This will improve the intracranial pressure also. Clear?
Yes, sir.
So raise the head of bed, intubate the patient, control the ventilation. So you will control ventilation according to blood gases. Well done. Excellent. Next one, Azam, or I think Rosamond.
Yes.
Rosamond, okay. So this patient has COPD. What is the difference between COPD and normal patient?
COPD, we can consider oxygen saturation up to 88 to 92.
Yes, in airway you will apply Venturi mask. Venturi mask. 4 liters, 28%. Clear?
Mask. Okay, yeah.
4 liters, 28%. Okay. So in COPD, here is a patient I will give you in breathing. I'm talking about breathing. So I will give you abrasion contusion in left side and the patient has paradoxical chest rise, it means this segment go up and the chest down. The other way around, this segment go down and the chest go up. Easy?
Yes.
It means a paradoxical chest rise. It means a flail chest. It means multiple fractures in the ribs. Okay?
Mhm.
So I will give you also tension pneumothorax. So the trachea deviated to the other side, hyperresonance in the same side of flail chest. Then it means the patient has flail chest plus tension pneumothorax. Okay? This in findings. Then call trauma team, including cardiothoracic surgeon. Then your intervention, it will be pain management for flail chest and the needle decompression and tension pneumothorax and the chest drain for tension pneumothorax. Easy?
Easy.
So, number one, intercostal nerve block. If the examiner asks you how to do intercostal nerve block, you will insert lidocaine with needle with syringe. It will be above the rib, above the rib. Okay? So in the target, intercostal nerve block above the rib. Easy
Yeah.
to avoid neurovascular bundle injury. You are numbing, it will be infiltrated. Yes, your target's the nerve, but don't insert inside the nerve. Your target to infiltrate intercostal nerve block infiltration. It means you are infiltrating beside the nerve. The lidocaine will spread. Anyway, then you will, if the patient in breathing, everything, no contraindication, it means the RR is high. It means you can give morphine. Yes. In circulation, you can give morphine. What if you want to give morphine nasal? The first line, the first line in major trauma is morphine. The second line is ketamine. So you can give morphine IV in circulation, but to reach circulation, you will take time, right?
Yeah.
So you are in breathing now, and you want to give morphine, right? So you can give intranasal, yes. But the problem, morphine contraindicated in hypotension and in bradycardia, yes. It means mandatory to wait for circulation. Did you get my point?
Yeah. Yes.
So, bradypnea, contraindication for morphine. Bradycardia, hypotension. 3. So, if you want to give ketamine without reaching the circulation, no problem. Especially this patient has COPD. Ketamine is better for him. Easy.
Easy. Yeah.
So, in breathing, you can give intercostal nerve block plus ketamine. It will be 1 milligram per kilogram. It will be nasal. Okay.
Yeah.
If you are in a hurry to give the patient something fast, or you can wait for circulation to give either morphine or ketamine. I wish it's clear. And of course, you will call the anesthetist for thoracic epidural in breathing. So now you finished the flail chest. What about tension pneumothorax? You will insert needle decompression in the fifth intercostal nerve, if the fifth intercostal space. I wish you are writing. You will insert the needle decompression 16 gauge cannula in the fifth intercostal space. Now I can hear his sounds. Don't ask the examiner, just verbalize. Now I can hear his sound. I will insert the chest drain in the fifth intercostal space, safe triangle. Don't talk too much about the safe triangle. This station is resuscitation, not procedure. So in procedure, you will talk in detail, but in resuscitation, brief about the procedure. Clear, doctor?
Yes.
So just to verbalize, I will insert the chest drain in the fifth intercostal space in the safe triangle, connect to underwater seal. Any bubbling, any swinging, any What about trachea after inserting the chest drain? What about SpO2, trachea, and percussion? You will ask about the 4 points. What about the tube in a bubbling, in a swinging? And then what about SpO2? What about trachea? What about percussion? Easy?
Easy.
Immediately. Swinging or bubbling, not enough. You should find improvement in SpO2, improvement in trachea, improvement in resonance. Clear?
Yes.
Once you correct breathing, when you go to circulation, you will find the blood pressure normal or abnormal.
So once we stabilize, then it will be normal. If it is not stabilized, then it will be abnormal.
Excellent, excellent, perfect. So if you insert a chest drain and you did not check the blood pressure, if you go to circulation, you will find the blood pressure became normal.
Yes.
But if you did not insert chest drain and you ask the examiner about blood pressure, he will say abnormal. Easy?
Easy.
Excellent. Do you need to go to circulation? No.
No.
Once you are in breathing, finish everything, correct everything, and then go to circulation, you will find all are normal. Easy?
Easy.
Okay. This was my station in my exam in India before. I got 9.5 in this station. Okay,
Wow.
9.5 out of 10. Okay, well done. You have 30 seconds and 6 minutes.
So 32 years, RTA, contusion of the COPD-1 nurse. Okay. COPD contusion. Okay. I can start now?
Yes, please.
Hello, good morning. I'm Dr. Rosimon, one of the ED registrar. Nurse, may I know your name and competency? We are expecting a patient with contusion on the chest and COPD. Could you please prepare airway trolley? And we need another nurse to help us with other things. So the patient is patient arrived. So the patient arrived.
The patient arrived, doctor?
Is there any handover from the ambulance or relatives?
Yes, the patient has chest injury. He was a driver, and this patient has history of COPD.
So this is driver coming with chest injury and history of COPD. So first time I need to do online immobilization. Is the patient conscious?
The patient is shouting, Doctor, I have severe chest pain.
So nurse, can you prepare some intercostal nerve block, 1% lidocaine, and some strong painkiller? So we will give you some painkiller. We'll put some, because the patient has got COPD, shall we put the Venture mask with 4 liter of 28% oxygen? Then we'll expose the chest and connect the monitor. And what about the respiratory rate? Oxygen saturation?
Ask about all one shot, doctor.
Oxygen saturation, respiratory rate, trachea, neck vein, inspection, palpation, percussion, auscultation of the lung and heart.
Yes, the patient has SpO2 is 70. The patient has RR 50. And the patient has paradoxical chest rise on left side, trachea deviated to the right side, hyperresonance left side, abrasion contusion left side, decreased chest rise and expansion left side.
So this patient has got low oxygen saturation, respiratory rate high, 55, and there is on the chest there is a paradoxical chest rise and also hyper resonance on the right side. So is the trachea is deviated, so there could be a pneumothorax and contusion of the chest. First, we need to do intercostal nerve block 1% lignocaine in the above the rib to avoid the injury, neurovascular injury, to infiltrate the area, and also we can give intranasal ketamine. And then contusion, so there could be a hyperresonance, so there is a pneumothorax. We can put 16 gauge needle in the second intercostal space at the mid-clavicular line. I can hear the hash. So how is the saturation now, and trachea and respiratory rate?
Improving now.
So this patient, we need to, because this patient has got flail chest and the pneumothorax, we need to call anesthetics to give epidural nerve block, and also cardiothoracic surgeon. In the meantime, we can try to do the ICD insertion in the fifth intercostal space, just in front of the mid-axillary line. So we will put the ICD and connecting with the water seal drain. And how is the tube swinging and bubbling?
Yes.
And how is the trachea now? Oxygen saturation?
Improving.
So thank you, team. The patient is improving. Is the anesthetics and cardiothoracic surgeon is here now? We'll move to circulation now. How is the BP, CRT, peripheral pulse, heart rate? I can reassess the airway. Is the airway still?
Continue, doctor. Continue. You have 9 points in
Okay, now
circulation.
so heart rate, abdominal I thought you were removing abdominal inspection, palpation, pelvic, is the pelvic stable? What about the long bone? And we need to do first to see any fore view to see cardiac and chest, cardiac.
Okay, all normal.
Okay, and we move to disability. How is the GCS now?
15.
Signs of lateralization, people equal and reactive to light, and how is the blood glucose?
All normal now. And the GCS is 15.
Okay, good. That's good. Is there any other abnormality, and how is the temperature?
Normal.
So the debriefing, we need to hand over this patient to cardiothoracic surgeon and cold anesthetics to give pain management. Go back to airway. How is the patient doing now? Yeah, is the airway still patent? Is the pain controlled?
Yes, the patient is not shouting anymore.
Okay, good, good team. Thank you. And how is the breathing? Is or the, oxygen saturation, respiratory, trachea, neck vein?
The SpO2 is 88.
So it's improving, which is good. We need to target an 88 to 92, which we are achieving it, which is good.
The blood gases is available now, doctor.
Okay, thank you. How is the blood gas?
What do you need?
I need PCO2, PO2, pH, lactate, please, bicarbonate.
The pH is 7.2 and the BO2 is 7, the BaCO2 is 7, and the bicarb is 15, and the lactate is 3.
Lactate is 3. So this patient may have the PCO2 is 7. It should be 7. Okay,
Okay,
so
thank you, doctor. Thank you. Your time done 30 seconds ago, but I tried to give you a chance. What is the interpretation, Razimon?
So we need to. This patient is hypoxic and acidotic, and PCO2 is 7. So this patient need intubation.
It means the patient has respiratory failure type 2, right?
Type 2 respiratory failure, yeah.
If the BaO2 is less than 8, it means respiratory failure. Easy.
Easy. Thank
BaCO2 is more than 6,
you.
it means the patient has respiratory failure type 2. Clear?
Yeah, thank
I
you.
don't care about type 1 or type 2.
Mhm.
Any BaO2, check the BaO2. Easy. What is your target?
PA2, more than 8.
Yes, BaO2. I don't care about the parameter now. So what is your target? BaO2. Easy.
Yeah, easy. Yeah.
If less than 8 kPa, it means respiratory failure. I don't care about type 1 or type 2. If you will say to the examiner, the patient ABG respiratory failure,
Mhm.
the patient needs the intubation. This patient conscious or unconscious?
This patient is conscious.
What is the GSS for this patient?
15.
It means he needs the intubation or rapid sequence intubation?
Rapid sequence intubation.
Induction or intubation.
Rapid-
Easy?
Yeah.
So you should mention like that. I wish it's clear.
Thank you.
If the ABG normal, no need for intubation. I'm talking about flail chest,
Mhm. Yeah.
and tension pneumothorax. Okay. So if the patient in respiratory failure, intubation, whatever, regardless of his GSS. Easy?
Easy.
Okay. It means the high flow oxygen not enough. The patient, do you think he
Hello.
needs? Do you
Hello.
think he needs salbutamol? Did I give you wheezes?
No.
No. In case I give you wheezes, for example, you insert a chest drain and you ask me, what about auscultation? I said the patient has bilateral wheezes. Then you can give salbutamol, ipratropium bromide, and then hydrocortisone, then check ABG again. Easy?
Easy.
But this patient has trauma. So the cause here, not medical. The cause here is trauma. So the patient has respiratory failure because of paradoxical chest rise, because of flat chest, because the reps is making problem in the lungs. Easy?
Yeah. Easy.
Okay. So I will give you 8 out of 10. If you mention intubation and
Yeah.
connect to back valve mask, one ventilation every 6 seconds, then you
Yeah.
will check the 4 points. I will give you 10 out of 10. Okay?
Thank you.
Welcome. Next one, the next station, Azan.
Yes.
Okay. So this patient has chest problem. I will make for you the open pneumothorax and tension pneumothorax. Okay?
Okay.
So I will give you the patient has abrasion contusion in the left side. The patient has wound in the left side. Then you should ask me, where is the wound? Which intercostal space? Your question should be clear, specific, direct. In which intercostal space? Easy.
Yes.
And then ask, is it penetrating? Then ask, is it sucking? Clear?
Okay.
So 3 questions for the one. Okay. Then you should ask in breathing about the 8 points. I said want in the left in the left side. The trachea deviated to the right side. Hyperresonance in the left side. Decreased chest rise and expansion left side. So the patient has open pneumothorax plus tension pneumothorax. Easy?
Yes.
So which is first? I'm talking about the management. Which one to manage first?
Open pneumothorax.
Yes, because this is a cause, right?
Yes.
So you will you will apply three-sided occlusive dressing and then chest drain. Chest drain away from the wound. If the wound in the fifth intercostal space, insert in the fourth. If the wound in the fourth, insert in the fifth. And if the patient is pregnant,
4.
in the fourth intercostal space, because in pregnancy, the diaphragm is high. If you will insert in the fifth, you will insert in the abdomen, not in the chest. Clear?
Yes.
Okay. So what if the examiner gave you open pneumothorax only. So he says that trachea is central. It means apply three-sided occlusive dressing only. Don't mention anything about chest drain. Clear?
Okay.
When to mention chest drain, maybe he will give you in the second breathing, the trachea became deviated and the hyper resonance it change now in the second breathing. Then you can insert chest drain in the second breathing. Easy?
Yes.
Okay, what if you want to mention chest drain in the first breathing and the patient has no tension pneumothorax? You should say like that. The patient has open pneumothorax, apply three-sided occlusive dressing. This patient can get tension pneumothorax. The patient can get tension pneumothorax at any time. So I will insert the chest drain to as prophylaxis. Easy as definitive treatment. Clear?
Yes.
I wish it's clear. So
Yeah,
you
it is.
should be careful here. Then the examiner will not consider it misconduct. Clear?
Yeah.
Okay.
Dr. Hani, regarding if I got patient type 2 respiratory failure, regarding intubation, we should mention clear bilateral sequence induction, and before that, make sure patient give medication. I mean sedation, or no need.
If the patient is conscious and he needs intubation, you will verbalize rapid sequence induction. The induction agent given, you can say, for example, propofol, blah blah blah, given. Clear?
Okay.
Done. But here, if you will say rapid sequence induction done, more than enough because no need to waste time.
Yes, clear.
Okay. So you have 30 seconds and 6 minutes. In second, the problem here, breathing, right?
Yes.
Breathing, any problem in breathing, whatever tension pneumothorax or open pneumothorax or flail chest or whatever. So your task, breathing. Remember that. So you will do blood gases. You will ask about blood gases in breathing, second breathing. You will ask about chest X-ray in second breathing. Clear?
Regarding case X-ray, Dr. Hani, assume done in first or ask I need to do.
No, you will ask about chest X-ray in the second breathing. If you want to ask in first breathing, accept it also. But first assessment, you can catch the problem without imaging. You can manage the patient without imaging. Clear?
Yes, clear.
You can manage the patient without ECG because you have monitor, right?
Yeah.
Any resuscitation station, whatever newborn or ABLS or ATLS or LS, you can catch any problem without imaging. You can manage and save the patient without imaging. And this is good, right?
Yes.
You can save the life of any patient, even in primary care. Clear?
Yeah. Clear.
Okay.
You can stop.
Yes, please.
Hi, my name is Dr. Azam, emergency registrar. May I know your name and level, please? I'm waiting for patient has chest injury. Please prepare all circulation and airway equipment. Patient arrive.
Patient arrived.
Any endorse from ambulance crew?
Yeah, this patient, he has chest injury. He was the driver. And this patient, he has history of COPD.
Okay, thank you. I'm going to assist my patient. Is the patient conscious?
The patient is shouting, severe chest pain, doctor, in the chest.
Okay, okay. Please prepare for me anesthesia. Patient shouting, that means airway patterns. I will do by manual line stabilization. Meanwhile, I will please apply cervical cola and apply oxygen 4%, 28, 4 liter 28% through Venturi mask. Please expose the case, connect all monitoring. I'm going to assist breathing. What about SpO2, RR, trachea, neck vein, case by inspection, palpation, percussion, auscultation?
The patient has SpO2 is 70, RR is 40, the trachea central, the wound 4 centimeter in the left side of the chest, abrasion contusions in the left side of the chest. And the normal air enters resonant bilateral.
Okay, where is the wound? The right side?
Left side.
Left side. In which intercostal space?
5th intercostal space.
Okay, is it penetrating?
Penetrating.
Is it sucking?
Sucking.
Okay, this patient, DSAT, oxygen saturation 70 at the kidney, RR 40, and there is a wound in left side, penetrating sucking. Patient has open pneumothorax. Please call trauma team, cardiothoracic team. Meanwhile, you need to apply three-side occlusive dressing. Okay. I will reassess breathing. What about SpO2?
Improving.
RR?
Improving.
Air entry?
Improving.
Okay, nice. I'm happy with B. I'm going to assess C. What about blood pressure? CRT, peripheral pulse, heart rate, abdominal inspection, palpation. And what about pelvic stable, long bone, any abnormality? And what about fast for free fluid collection in 4 view?
All are normal.
Okay, great. Please insert white bore cannula, extract blood for hematology biochemistry, blood group and safe cross match, and blood gas toxicology screen. Okay, I'm going to assess disability. What about GCS? Any sign of lateralization? What about pupil? Random blood glucose?
The patient is shouting. He has severe pain in the...
Please, okay, please give morphine, 5 milligram IV, and titrate up to 20 milligram.
GSS is 15 and normal pupils, no signs of lateralization, blood sugar 5 millimole.
Okay, great. I'm happy with the D. Please insert urine catheter to monitor urine output. Meanwhile, I will continue to assess exposure the patient. Any sign, any abnormality? What about temperature? Okay, I need to endorse my patient to trauma team, including cardiothoracic team, patient for admission and observation. Anyone available? Okay, meanwhile, I will reassess the patient. Is this airway pattern? What about SpO2 RR?
SpO2 is decreasing now. It's 50 and RR is increasing 60.
Okay, what about trachea?
Deviated right side.
Okay, and what about neck vein?
Neck veins are congested.
Chest by percussion?
Hyperresonance left side.
Auscultation?
Decrease their entry left side.
Okay, my team patient develop attention pneumothorax. Please call trauma team, including cardiothoracic team. Meanwhile, I will apply chest drain in 5th intercostal space and connected with underwater seal. Any bubbling, anything in there? Okay, what about SpO2? SpO2 after
Improving
chest
now.
drain
Improving.
and RR
Where you will insert the chest drain?
in 4th intercostal space.
Okay, everything improving now.
Okay, great. Any blood gas available in X-ray?
Blood gas is available now.
Okay, what about pH, PO2 and PCO2 and bicarb and lactate?
The pH is 7.3 and the PO2 is 8.5 kPa. PaCO2 is 6 kPa and the bicarb is 15 and the lactate is 2.
Okay, patient has history of COPD and PO2 less than 8. I'm considering respiratory failure.
I said 8.5 kPa.
8.5.
PO2 8.5 kPa.
8.
PaCO2 is 6. Thank you. Your time done.
Yes, thank you.
Okay. What do you think about this blood gas?
I'm hearing first 8.5, less 6 I'm hearing.
Anyway, so the blood gas is accepted, right?
Yes, normal, accepted for this
Accepted,
patient.
not normal, but accepted, okay?
Yes, yes,
So the PO2 more than 8, not respiratory failure.
yeah,
The pH 7.3 acidosis and
yes,
accepted because of COPD. Any pH above 7.25 accepted for COPD. Easy.
yes, yes,
Any PO2 above 8 accepted for COPD.
yes.
And the PSO2 is 6. Okay, good. So this patient needs intubation?
No need.
No need. You should say accepted for this patient COPD, and in the meantime, we should observe this patient in ICU.
I see that.
Okay.
Yes,
So this patient, excellent guys. We applied three-sided occlusive dressing for open pneumothorax. We inserted chest drain for tension pneumothorax. Then we need to confirm that by X-ray, and the ABG is accepted. So no need for intubation at the moment. Easy. We are waiting for cardiothoracic surgeon to admit this patient in ICU team for observation. Easy.
yes.
Okay. I will give you 8 out of 10. I optimized your diagnosis and the management plan. Okay,
Okay, thank you.
welcome. Nikesha,
Yes, Dr. Honey.
how are you?
Fine, thanks.
Okay, what is your station?
Massive hemothorax.
Okay. Azam, did you mention the cause of shock, obstructive shock?
Yes, for sure, obstructive, but
But I give you the blood pressure normal.
yes,
So no need to mention about the shock. And also for Rosimon, I give the blood pressure normal because you treated the breathing, right?
Yes.
If you treat the breathing, for sure, even in the exam, the examiner is intelligent. If you treat the problem, he is sure that the blood pressure will be normal. That's why he will give you blood pressure normal. If you did not treat the problem and jump to circulation, if you ask him, he will give you blood pressure is abnormal. In such a case, you should say obstructive shock. But anyway, I don't prefer to jump to see circulation. In the real practice, yes, you have one nurse to check vital signs, you have one nurse to check blah blah blah, and you are doing blah blah. So everything simultaneously. So they will give you parameters of breathing with parameters of circulation. So she will say the patient is hypotensive. Clear, guys, in real practice. Okay. But again, don't give fluids for blood pressure. If you will give fluids for obstructive shock in trauma, you are harming the patient. When to give in obstructive shock in pulmonary embolism, and even in pulmonary embolism, the main treatment is oxygen, whatever high flow oxygen non-respiratory mask. I'm talking about ALS, pulmonary embolism. So you can give high flow oxygen non-respiratory mask or back valve mask or intubation. Then, if the blood pressure is still low, you can give fluids. Okay. Nikisha, this station I will make for you a massive hemothorax, okay?
Okay.
So the patient has a stab wound and the object in the chest. Do you think you can remove the object?
No, Dr. Honey.
No, don't remove the object. Don't touch the object. Don't do dressing. Okay? So any object in the chest or in the abdomen, guys, don't remove. Even object in the head, don't remove. Object in the leg, don't remove. So any object inside the body, don't remove. Why? The object tamponating the bleeding. Whatever knife or any object from road traffic accident, maybe he has object from the car inside his body, so don't remove. Anyway, so the patient has stony dullness left side, trachea deviated right side, and the patient has object in the left intercostal space, fifth intercostal space. Then you can insert chest drain away from the object. Easy?
Yes, Dr. Honey.
Okay. So you have 30 seconds. I will give you more idea. So here, once you insert a chest drain, you will connect it to underwater seal, and you will ask about 4 points as intention pneumothorax. Number 1, any blood? He will say yes. How much? He will say blah, 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 blah. Then what about SpO2, RR, and percussion? Again, easy.
Okay.
All should improve. All should improve. So if you find the blood in the underwater seal more than 1500 cc, this patient needs ED thoracotomy.
Okay.
ED thoracotomy or theater thoracotomy?
ED.
ED, so you should do thoracotomy in ER, okay? So anyway, once you find trachea improving and the stony dullness improving, maybe dullness but not stony anymore, clear? The trachea improving, not deviated anymore, and the SpO2 is improving, then you will go for circulation. You will ask about the 9 points, clear?
Yes.
You will find the high potential, but fast negative, everything normal. Then this patient, you will insert 2 IV access, extract blood for blah, 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 blah. And then start 4 units back the RBCs. Easy?
Yes, Dr. Hani.
Okay. Don't ask the nurse available or not. In the exam, don't ask the examiner available or not. So you want to give something? Give. You want to do intubation? Do. Don't say, am I competent or not? No. This is wrong. Clear, doctor?
Okay.
You want to intubate? Intubate. You want to do sclerotomy? Do. You want to give fluids? Give. You want to give blood? Give. But fluids, I'm advising people, fluids in trauma contraindicated. Fluids in trauma contraindicated. Fluids kill the patient. Blood transfusion saves the patient. So blood plus blood stop bleeding. Fluid plus blood increase bleeding. Clear, doctor?
Yes.
So number one, you will give the 4 units back to RBCs, same blood group. The examiner silent, the nurse silent, it means a given. If the examiner or the nurse said same blood group not available, he means cross match not available, then you can give O blood group. Easy?
Yes.
So O blood group, this patient male. So you are preparing your mind in 1 minute preparation. I will give O positive blood 2 units. So don't say available or not. You can say give the patient 4 units, back the RBCs, same blood group. They are silent, be happy. Done. Easy?
Yes.
Okay. You have 30 seconds and 6 minutes. In the second breathing, you can ask again. In the second breathing, you can ask again about SpO2, trachea, and how much blood in the underwater seal and about percussion. Why? To confirm the patient is improved and also how much blood in the underwater seal to compare with the previous amount. Clear?
Okay.
If the previous amount same, it means the patient has no more bleeding. Good. If the patient is still bleeding but less amount, for example, he has 1,600 in the first assessment, and then you give him 4 units back the RBCs. In the second breathing, you find the blood in the underwater seal 2,000 cc. No problem. It's not bad. Clear now?
Okay.
But if you find, for example, 3 liters, no, this is very serious. Easy.
Okay.
So if the blood input more than the blood output, good or bad?
Bad. If the output is more than the input.
No, I said blood
The
input
other way.
more
Okay,
than
good.
the blood output. So
Good.
good. I wish it's clear. You have 30 seconds and 6 minutes.
Good afternoon. I'm Dr. Thomas, ED Registrar. May I know your name and competency? Are you ATLS trained? Thank you. We have one nurse. May I have another nurse, please? We are expecting a patient coming in with an injury to the chest. Could you please prepare the airway equipment and circulation equipment?
Patient arrived.
May I have the handover from the ambulance crew?
Yeah, the patient has a road traffic accident and we extracted him from the car. He has chest
Okay.
injury and the object in the chest.
Okay, thank you. I would apply manual inline stabilization. Is the patient conscious?
The patient is shouting severe chest pain.
Okay, the patient is shouting, so we have a patent airway, but is there any blood or secretions in the mouth?
Airway is patent.
Okay, could we apply a cervical collar, apply a non-rebreathable mask at 15 liters per oxygen? Thank you. Expose the chest and connect all monitors, including blood pressure, SpO2. May I have the SpO2 of the patient, RR, trachea, neck veins, is it engorged? Inspection, palpation, percussion, auscultation of the lungs and heart.
The SpO2 is 50 and the RR is 50. The trachea deviated to the right side. The patient has object in the left side of the chest in the fifth intercostal space and high stony dullness in the left side. The patient has decreased air entry in the left side, decreased chest rise and expansion left side.
Okay, team, we have a patient with a penetrating injury to the chest who is hypoxic. He's also tachypnic. Patient has stony dullness on the left side of the chest, and the object is in the fifth intercostal space. We are dealing with a patient here. Trachea is also deviated, so we are dealing with a patient here with a possible massive hemothorax and tension pneumothorax. Nurse, may I have a 32 French chest tube, sterile equipment, and lidocaine, please. We are going to insert, I'm inserting a chest tube in the fourth intercostal space away from the object. In the anterior to the mid-axillary line, in the safe triangle, attached to the underwater seal. Am I seeing auscultation or blood draining from the tube?
The blood amount 1,600 cc in the underwater seal.
Okay, guys, we have blood draining from the tube more than 1,500. Could we also prepare for an emergency thoracotomy? Emergency thoracotomy done. Could we reassess the patient, please? How is the SpO2?
The surgery team is not available and you are not competent in emergency thoracotomy.
Could we contact the cardiothoracic team and also prepare
Not available. Not available.
And I'm not competent. Could we contact the OR?
Okay, continue. What do you want to ask about trachea?
Is the trachea
improving now? Improving.
SpO2?
Improving.
Percussion?
Improving.
And rise and fall of the chest? Auscultation?
Improving.
Okay. What's the patient's blood pressure?
Blood pressure not recordable.
Look, listen, and feel for signs of life.
I still have signs of life.
Capillary refill time, peripheral pulses, abdomen inspection, palpation. Is the pelvis stable? Exposed long bones for any deformity?
All are normal.
Pardon?
All are normal.
No. Okay. GCS of the patient?
What you will do in circulation?
Oh, sorry. Apply 2 large bore IV access. Could we have blood drawn for full blood count, use and ease, blood gas? Could we also activate the massive blood transfusion protocol, requesting 4 units of red blood cells, cross match? GCS of the patient? We have a hypotensive patient, so could you go ahead and give the patient
what you will give this patient? What you will give this patient?
Could we go ahead and give this patient 4 units of packed red blood cells?
Okay.
For blood given. Is the blood pressure improving?
Don't ask about blood pressure now. You ask about blood pressure in the second circulation.
May I have the GCS? Any signs of lacerations? Are the pupils equal and reactive on blood sugar of the patient?
GCS is 14 now, and pupil normal, blood sugar normal.
If we expose any other abnormalities on temperature?
Normal.
Okay, guys, let's quickly reassess the patient. Airway still patent?
Yes.
SpO2?
SpO2 is decreasing.
RR?
RR increasing.
Trachea?
Trachea central.
Auscultation?
Auscultation decreased air entry in the left side.
Percussion?
Percussion still dullness.
Could we, I said they're not available.
Okay, thank you. Okay, what do you think, Nikisha?
It's my first time. I just got thrown off when you said that the surgeons were not available. Like, what do I do? I am not competent and surgeons not available. So
Okay,
that kind of threw
so
me off.
you are competent if the examiner did not consider you are not competent. Did you get my point?
Understand. Mhm.
So you want to do anything, you can do. If the examiner is silent, done. If the examiner said not available or you are not competent, he can decide. Easy?
Okay.
For example,
I
you
think I
said,
said that I was going to do the emergency thoracotomy, and then you said that I wasn't competent. So that threw me off.
yes, no worry. So when you say give the patient 4 units back the RBCs, I was silent. It means a given.
Okay.
If I said not available, then you jump to the next action. Give O blood group 2 units. Easy, back the RBCs.
Okay.
Okay. If I said not available, then you can give fluids 250 ml. Easy.
Easy. Mhm.
And so on. So here, emergency thoracotomy can save the life? Yes. But you have alternative. What is the alternative? Chest drain and the blood transfusion, right?
Okay.
If you have no surgery team in your hospital, okay, you are in primary care, for example, and you don't have surgery team at all, not even general surgery, you can save the patient? Yes. Chest drain, even you did not insert a chest drain before, don't worry. You will insert the chest drain in the fifth intercostal space and try to put all the holes of the tube inside the chest. Okay? You have like 3 holes or 2 holes in the tube, in the top. Okay? So be sure all of them inside the chest. Easy?
Okay.
And connect it to underwater seal. Then give the patient blood transfusion. Once you do that, you are saving the life of the patient. Why? You are giving him 4 units back the RBCs. It will take like 1 hour, more than enough to transfer the patient. Easy?
Okay.
So you are starting blood transfusion. Don't worry. The patient with chest drain, it means no more pressure on the heart. Easy?
Mm-hmm.
You are
Yeah.
releasing the pressure on the heart. So there is pressure outside the heart, in the chest. Easy?
Yes.
And then you are giving blood transfusion to correct the blood volume. Don't worry, you are doing well. I wish it's clear.
Yes, Dr. Lani.
So if you have surgery team in the hospital, for sure they will send it to theater. So you will catch the problem in breathing. So full assessment in breathing, full findings. You will say the patient has blah 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 blah. It could be massive hemothorax. Where? In the left side. You should mention the side. Clear?
Okay.
Call trauma team including cardiothoracic surgeon, and then activate massive transfusion protocol. Where? In call. And prepare theater. Where? In call. Easy? So
Okay.
call here very, very important in the first breathing. Okay? So in first breathing, full assessment, full finding, full call. So any bleeding, whatever traumatic or non-traumatic, you should prepare theater. Easy?
Okay.
I'm talking about any bleeding with massive blood loss What does it mean, massive blood loss? The patient are R more than 30, the heart rate more than 110, systolic blood pressure less than 90, or the patient has massive hemothorax. How to know it's a massive hemothorax? Stone dullness, deviated trachea. In such a case, you should call the team, activate massive transfusion protocol, prepare theater. And then your intervention, insert chest drain, connect it to underwater seal, and ask about improvement. Easy.
Okay.
Then in circulation, you find the patient everything normal except the stability. So abdomen inspection palpation normal, pelvis stable, long bones no deformity. You did not ask about fast, normal, but blood pressure abnormal, peripheral pulses abnormal, and heart rate sinus tachycardia. Okay, so you can say the patient has hypotension with sinus tachycardia. It could be hypovolemic hemorrhagic shock. Did you mention that?
No, Dr. Hani.
Because of what? Massive hemothorax. Easy.
Yeah.
Already we activated massive transfusion protocol. The setter is ready now. You in breathing, you activated. In circulation, you can confirm. Okay. Then you can start insert two IV access, extract blood for hematology, biochemistry, blood gases, blood culture, toxicology, screen group, and save cross match. Then start 4 units back the RBCs. The examiner is silent, the nurse is silent, done. Then go for disability. You will ask about the 4 points. Exposure, 2 points. Then I need to hand over this patient to surgery team, cardiothoracic surgeon. The setter is ready, guys. Then you will go for airway, breathing, circulation. In circulation, first circulation, don't ask about blood pressure after 4 units back the RBCs. Why? If you ask about blood pressure in the first circulation, still low, right?
Yes.
You will stop in C. Then if I say low, you will give again blood transfusion. You will ask me, I will say low. It means you will not reach D. You will not reach E. Did you get my point?
Yes.
That's why I advised you, don't ask about blood pressure again in the first circulation. You will ask about blood pressure in the second circulation. Easy, doctor?
Yes.
And stop in the second circulation. Because you finished your task. If you finish the A, marks, B, marks, C, marks. If you stop in the first C, no marks for D, E, handover, and blah, 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 and maybe the time will finish. Easy?
Yeah.
But if you finish D, marks, E, marks, handover, marks, then second A, second B, second C, you are collecting marks. I wish it's clear.
Yes.
Then if you stop in the second C, no problem. You finished all your points. Okay?
Mhm.
So here you did not reach the points of uh, blood transfusion. You did not reach the point of primary pack, secondary pack. It means you did not reach the end of the task. So I will give you 8 out of 10, okay?
Okay, Dr. Hani.
Thank you. Okay, next one.
Dr.
Abbas?
Hani, please.
Yes, please.
Here in in secondary assessment, if I found parameter of breathing, for example, Dalton percussion like this, we should announce again cardiothoracic team and prepare theater and continue massive transfusion blood or
Confirm. Already you called them, right?
yes.
So in second breathing, you will say, what about theater ready, guys? What about cardiothoracic team available now? Like that.
And Dalton percussion, that means he's still patient on bleeding and partially improved.
Yes, if the trachea normal and the patient is still dullness, this accepted, don't worry.
Mhm.
Okay, so
Okay.
already the tube is working. The tube,
Yes.
you should ask about how much blood again in the second breathing, right?
Yes.
You should ask about X-ray in the second breathing. You should ask about X-ray and E fast, guys. X-ray and E fast in major trauma, okay, in breathing.
Yeah.
And regarding the blood gases, you should ask in second breathing. So um, she forgot to mention these points, okay?
Okay.
So here in second breathing, you should confirm by blood gases, by X-ray, and you should confirm by the buoyance. Buoyance, it means how much blood in the underwater seal. For example, if I said 2000 cc, you can say, excellent, guys. We are giving the patient 4 units back the RBCs, but he lost only 500 cc or 400 cc. Okay, like that.
Okay.
It means the input more than the output. Clear?
Yeah. Good sign.
Yes. Okay. Thank you. Next one,
Thank you.
Abbas.
Yes, sir.
What is your task?
Sir, a blunt abdominal injury, sir.
Okay. So this station, yes, this one. Okay. So abdomen blunt injury, it could be liver, it could be spleen, right?
Yes, sir.
So you will find the airway normal. You will find the airway normal. Breathing may be normal. Circulation, you will find hypotension, and abdomen inspection may be abrasion or contusion. Clear?
Yes, sir.
Palpation also tenderness if stable, if conscious. Pelvis may be
Yes.
stable. Long bones
Yes.
normal. Fast is positive in the upper quadrant, may be right or left. Easy?
Yes, sir.
Okay. Then what you will do, insert the two IV access. You will verbalize the findings first before call.
Yeah.
So full assessment, you will ask about 9 points in abdomen. In full findings, you will say the patient has a contusion in the right upper quadrant and the tenderness. It could be with hypotension, with positive fast. It could be
Liver injury.
hypovolemic hemorrhagic shock because of liver injury.
Yes,
Easy?
sir. Yes, sir.
So liver injury not enough.
Yes, sir.
Liver injury, maybe the patient is stable, maybe no hypotension, maybe no bleeding, right?
Yes, sir.
So you should say like that. The patient has hypotension, abdomen inspection, contusions, and tenderness right upper quadrant, positive fast. It could
Yes, sir.
be hypovolemic
Uh,
hemorrhagic shock because of liver injury. Then call.
yes, sir.
Call trauma team, surgery team, activate massive transfusion protocol, prepare theater because this patient needs.
Emergency laparotomy.
Excellent. Easy.
Thank you, sir.
Then intervention. Insert the two IV access, extract the blood for hematology, biochemistry, blood gas, culture, toxicology screen, and then blood group and save. Then cross match. Easy.
Yes, sir.
Then give the patient how many units?
4 units packed cells, sir. Same blood.
Back the RBCs. Excellent. Same blood group or cross match. Easy.
Yes, sir.
So you should mention that. Then don't ask about blood pressure. Go for disability, for exposure, hand over this patient to blah, 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 blah. I will reassess the patient. So finish second A, second B, second C. Then in second C, I want you to stop. Easy?
Yes, sir.
And then you will ask, what about blood pressure? Still low. Then ask, any blood results? Yes. Correct them. If he said no blood results, give blind. What does it mean,
Yes,
blind?
sir.
You will say 4 units backed RBCs, 4 units fresh frozen plasma, 1 unit platelet. This is called blind. But if
Yes, sir.
you have blood results, don't give blind. It means you should correct the abnormalities only. So if hemoglobin only low, you will give 4 units backed RBCs only. If INR only high, you will give 4 units fresh frozen plasma. If platelet only low, you will give only 1 unit platelet. I wish it's clear.
Yes, sir.
Okay, you have 30 seconds and 6 minutes.
Sir, should I start?
You can start.
Hello, my name is Dr. Mohammad Abbas Khan. I am the ED registrar here. May I confirm your name and levels, please? Okay, can you prepare airway equipment for me? Are you a ATLS provider? Can you prepare the circulation equipment for me? The patient is about to arrive and he has a suspected blunt trauma to the abdomen. Has the patient arrived?
The patient arrived.
Okay, any hand over from the ambulance crew?
Yes, this patient has a road traffic accident, and we extracted him from the car. The patient has a major abdomen injury.
Okay. Okay. Okay, I will put in manual inline stabilization. And okay, is the patient conscious?
Drowsy.
Drowsy. Okay. Okay, is the airway patent?
Patent.
Okay, kindly connect high flow oxygen. And what about, okay, expose the chest and connect all the monitors. What about SPO2, respiratory rate, trachea, neck veins, inspection, palpation, percussion, auscultation of the lungs, and heart sounds, please?
Normal, all normal.
Okay. What about the blood pressure, CRT, peripheral veins? Okay, what heart rate, and what about the inspection palpation of the abdomen?
The blood pressure, continue, doctor, continue.
Okay, okay. What about the pelvis? Any pelvis is stable, and kindly also tell about the long bones. Is there any deformity? Okay. Also tell me about the fast of the four views of the abdomen.
Okay, the blood pressure is not recordable. CRT is not palpable. Peripheral pulse is not palpable. Heart rate, this one. And the abdomen inspection, the patient has right upper quadrant contusions. And regarding the tenderness in the right upper quadrant, the pelvis is stable. Long bones are normal. Why do you need fast, doctor?
Okay, I want to check any free fluid in the abdominal cavity.
Where?
Oh, okay, all the four quadrants, four views.
You should say in the right upper quadrant
Okay, in the right upper quadrant
and the other views.
and other views.
Yes, the patient has positive fast in the right upper quadrant.
Okay, guys, this patient is having fluid, this blood in the right upper quadrant, and he has low blood pressure, and blood CRT is high. So this is mostly due to the hemorrhagic shock due to the blood in the right upper quadrant due to the liver injury. So give put IV access and take the blood for hematology, biochemistry, blood gas, blood culture, toxicology screen, and also activate must have hemorrhagic protocol, and I'll call the trauma team and surgery team and prepare the operation theater. This patient needs urgent emergency laparotomy. Okay. Also, I will move for the D. Any signs of what about DCS? Any signs of lateralization and RBS? And also pupil size, please. Okay, I will move to the exposure. Expose all the body and any other abnormality. What about temperature? Okay, okay, any trauma team and surgery team arrived. I will need to hand over this patient for the admission for the observation and treatment. And is the OR operation theater ready?
You said
Okay,
observation, you said for observation, and you said surgery. So what do you need, observation or surgery?
surgery, emergency surgery.
So not observation.
Oh, yes, sir, yes, sir.
Okay, continue.
Oh, okay, I will reassess the patient. What about SpO2 respiratory rate?
Normal.
Okay, what about blood pressure and CRT?
Still low.
Okay, the blood pressure is still low. Kindly give the massive hemorrhage protocol and give 4 units of the packed cells. Is the blood pressure low still?
Yes.
Okay, kindly and any blood results available?
No blood results.
Okay, kindly give the primary pack, 4 pints of the red blood cells and 4 FAPs, and also give 1 platelets. What about the blood pressure?
Low.
And any blood results available?
No blood results.
Okay, so kindly give the secondary pack, including the 4 packed cells and 4 FAPs and 1 platelets and 2 cryoprecipitates. So what about the blood pressure?
Thank you. Your turn done.
Yes, sir.
Okay. Thank you, Abbas. So in the
Yeah.
first circulation, did you give 4 units backed RBCs?
Yes, sir. My mistake, sir.
Okay. You did not, right?
Yes, sir.
So how you will save the patient and you are ignoring the blood pressure? Okay.
Yes, sir.
The patient
Yes,
will
sir.
die if you will not
Yes, sir.
start. You have two options: blood transfusion or fluids.
Yes, sir.
We are against the fluids, but if you will not give blood transfusion, at least give fluid. Easy.
Yes, sir. Yes, sir.
Even for the purpose of the exam, if you will not mention blood transfusion, at least mention fluids. Clear?
Yes, sir. Yes, sir.
Okay. So the fluids here, even 250 ml, it will be for 15 minutes. 15 minutes more than enough for your team to come. Your team will come within 1 minute, right?
Yes, sir.
They will save the patient. Even you are not safe doctor, they will save the
Yes,
patient.
sir.
Easy.
Yes, sir.
You forgot, for example, massive transfusion protocol, but once the surgery team arrive, once the trauma team arrive, they will confirm, did you activate, did you blah, 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 did you blah, blah, blah. They will do the needful for the patient. Easy. Okay.
Yes,
Well
sir.
done. So here in circulation, you ask about the all points. Here you have full assessment, then full findings, but you did not call. You started intervention without call. Clear?
Yes, sir.
Call is safety. Call is safety. Once you call, you will find your team immediately, even before you insert the two IV access. Clear?
Yes, sir.
They will do the needful for you. So which is better, call or intervention?
Call, sir. Call.
Call. Clear?
Mm.
So you should
Yes, sir.
mention the finding. You should say the, and here I ask you, why do you need fast? The patient has
Mm.
contusions in the right upper quadrant. So why do you need fast? To check any free fluid collection in the right upper quadrant and other views, right?
Yes, sir.
Patient has contusion in the right upper quadrant. So your suspicion now, positive fast in the liver area. Easy.
Yes, sir.
It should be like that. So call. You should say, call trauma team, surgery team, prepare theater for emergency laparotomy. You said for observation. Is it logic?
No, no, sir.
You want to observe if the patient is dying or not?
No, sir.
I'm joking. Okay.
Yes.
So you should prepare theater for emergency laparotomy. Okay. So
Yes.
you will activate massive transfusion protocol. You will call surgery team. You will prepare theater. Then your intervention, insert two IV access, extract the blood for blah, 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 and give 4 units bagged RPCs. Easy?
Yes, sir.
So you have problem in full call and intervention. I wish it's clear.
Yes, sir.
Okay.
Yes.
I will give you 8 out of 10. You did well in the second
Thank you.
circulation. You give the patient
Yes, sir.
you give the patient primary back and the secondary back because I ignored the blood results. Okay, so well done. Thank you. Next one.
Thank you, sir.
Welcome. So, when you say emergency laparotomy, you can say because the patient has hypotension, abdomen blunt injury, and the positive fast. You should mention the 3 points because blunt. In penetrating, the next station, Edis,
Yes, please.
is this your station, penetrating?
Okay.
I'm asking you.
Yes, yes.
Okay, I want to confirm.
Yeah.
So, in penetrating, the indication to do emergency laparotomy, hypotension, and penetration. Easy.
Yep.
If you find the patient is hypotensive, don't ask for fast. Clear?
Yes.
If the patient is stable and penetrating, you can do fast? Yes or no?
We can do fast without
Yes.
touching the wound
Yes.
and stab.
Yes. I said yes or no. Yes. Okay. So, any penetration in the abdomen, some people think contraindicated to do fast? No. If stable, do. Because stable, you have time.
Yeah.
Unstable, don't do.
Okay.
Because already unstable, it means he needs a surgery. I don't care about fast. Easy?
Yes.
Okay. What are the indications of emergency laparotomy if the actor asks you in the exam, or if the nurse asks you in the exam, or if the examiner asks you in the exam? If you finish the station, maybe the examiner will ask you. So you remember this, guys. So if abdomen, blunt injury, positive fast, hypotension. What else? Abdomen, penetrating injury, and hypotension. What else? The patient CT scan show bowel injury, or the patient has bleeding from mouth. So if you ask me, what about airway? I said the patient has bleeding from mouth. So this patient needs the emergency laparotomy, even stable. Easy?
Yep.
So any bleeding from any orifice, it means he needs emergency laparotomy. I'm talking about abdomen injury, whatever penetrating or blunt. He has bleeding from urethra, bleeding from rectum. So he needs emergency laparotomy. What else? Gunshot. If they mention in the scenario here, gunshot in the abdomen. So this patient needs emergency laparotomy. What else? Evisceration. When you ask the examiner, what about blood pressure? Normal. But he said in an inspection, you find evisceration. It means part of the bowel outside the skin. So this patient needs emergency laparotomy. Clear, guys, these points? Okay.
Yes.
So this station same as previous station, but you will keep the object. Don't move. Easy, doctor?
Yes, please.
Okay. Everything same as previous station. You have 30 seconds and 6 minutes.
Can I start?
Yes, you can, please.
Hello, I'm Dr. Edith, one of the emergency registrars. May I know your name and your level, please? Are you ATLS trained? Perfect. We're expecting a patient with a stab wound, prepared in circulation airway trolleys. Are the ambulance crew here? Any handover from the ambulance crew?
Yes, we found this patient in road traffic accident. We extracted him from the car and we found object from the car in his abdomen.
All right. Patient was extracted from the car following road traffic accident with a stab wound on the abdomen. Manual inline stabilization. Is this patient conscious?
The patient is shouting severe abdomen pain, doctor.
All right. Can we prepare IV morphine for this patient and get it ready? Since the patient is shouting, the airway is patent. I will apply cervical collar, high flow oxygen for this patient, please. As we stabilize the area at this point, let's move on to breathing. Can we quickly connect this patient to monitor? Suppose the chair to connect to monitors. How about the RR, SpO2, trachea, neck vein, inspection of the chest, palpation, percussion, and auscultation of the chest and lung?
All are normal.
All right. The breathing is normal at the moment. However, can we put out a trauma call and then get in touch with the anesthetist, the ITU team, and then the general surgeons to be around, because this patient might require emergency laparotomy because of this penetrating injury. Moving on to circulation. How about the blood pressure, CRT, heart rate, inspection of the abdomen, palpation, percussion? Is the pelvic stable? Any long bone deformity?
The patient blood pressure is not recordable. Pelvis is stable, long bones are normal, and the patient has object, stab, wound in the abdomen, left side, upper quadrant.
The patient is sinus tachycardia, blood pressure not recordable, stab wound with object in the left upper quadrant. Is this look, listen, and feel? Is this patient still alive?
Yes.
All right, patient is still alive. We've put out a trauma call and we've got in contact with the general surgeons. Can we get the operation theater ready, please? And then, as we are expecting them, let's treat this patient. Can we get a whiteboard cannula in 2 hands? Collect sample for biochemistry, microbiology, hematology, group and save and cross match, and then blood gases. In the meantime, can we start this patient on the 4-unit pack RBC patient home blood group while we are waiting for the surgeons? Can we move to disability? How about this patient's GCS, signs of lateralization, pupils, and the BM, please?
Did you give 4 units back the RBCs?
Yes, please.
Okay. So the disability, what do you need from disability?
The GCS at the moment, lateralization sign, BM, and pupillary reaction?
All normal.
All right, the disability is reassuring at the moment. Let's move to exposure. Any other abnormality? How about the blood, the temperature?
Temperature is 33.
Temperature, this patient temperature is on the low side. Can we cover this patient and then convert the air condition to warm, and then just make this patient as comfortable as possible? Let's go back and reassess the patient. Is the airway still patent?
The airway is still patent. The patient is still shouting.
All right. Airway is patent, patient is shouting and he's hypotensive. Can we give this patient ketamine to reduce pain? At the surgical team here and the anesthetist. And then how about the blood pressure? How about the RR and SpO2 at this point?
RR is high and SpO2 normal. Breathing normal except the RR above 30.
All right, the breathing is reassuring at the moment. Moving on to circulation. How about the blood pressure and the heart
Low.
rate at the moment?
Blood pressure is still low.
Blood pressure is still low. Is the OR ready? Are the general surgeons here? We've given the first pack unit of RBC. Any blood tests available? Since there's no blood results available, let's give a primary pack, 4 units pack for RBC, 4 FFP, and 1 platelet. Are the surgeons here? Is the OR ready? Let's reassess this patient's circulation. What's the blood pressure and the heart rate at the moment?
Still low.
Any blood results available?
Yes. What do you need, doctor?
Please, HB, platelets, INR.
The hemoglobin is 5, INR 3, and platelets 40,000, and the fibrinogen is 1.
All right, team, the HB is too low, the platelets is low, and then the INR is on the high side while the fibrinogen is low. Can we give this patient 4 units of pack RBC, 4 units of FFP, 1 platelet, and 2 cryoprecipitates? Is the OR ready? Are the surgeons available?
The surgery is busy and the theater is busy and the patient is still hypotensive.
All right, team, don't give up. Since the surgeons are still a bit busy at the moment, let's continue transfusing this patient. Any blood result available?
No.
All right, so we'll continue with the secondary pack. 4 units. How about the blood pressure and RR and the heart rate at the moment?
Still low.
Still low. 4 units of pack RBC, 4 units of FFP, 1 platelet, and 2 cryoprecipitates, please.
Okay, thank you. Thank you. Excellent. It is. Did you mention surgery team, theater, this patient needs emergency laparotomy?
Yes, but I
Okay,
did not mention the indication.
yes. So you should mention because the patient has penetrating abdomen injury and hypotension. Did you mention that?
No, I missed that one.
You should show the examiner why emergency laparotomy. Why? Because if you did not mention that, it means any abdomen injury, you want emergency laparotomy, right?
Yeah, noted.
It's not logic. Any patient has object in the abdomen, you will do emergency laparotomy. Maybe superficial, right? Maybe superficial injury, right? Okay. So you did very well. I will give you 9 out of 10. You are perfect. Thank you. You
Thank you.
finished your task. You are controlling your time. You are very organized. All the points are done. If you mention because of hypotension and penetrating abdomen injury, then I will give you 10 out of 10. Okay?
Thank you.
Well done. Aiki? Aiki?
Yes, sir.
I don't know if this is your turn or not.
Yes, I'm not sure, but I'm
What
supposed to
is
do
your
pelvic
task? What is your task?
limb amputation.
Okay, we
No,
will
sir,
see.
it's my pelvic
Pelvis?
fracture.
So
Yes.
Sondos. So Sondos,
Yes.
okay? Sondos, this is your turn. Pelvis. This station
Yes.
is very straightforward. So you will find airway normal, breathing normal, circulation, everything normal except the blood pressure and the pelvis is unstable. Easy?
Yes, sir.
Maybe the examiner will make mildly difficult, okay? Slight, okay?
Mhm.
So he will say, for example, thigh deformity and the leg deformity. So thigh one limb, leg in the other limb deformity. If you find the pelvis is unstable plus deformity in lower limbs, don't do a skeletal traction for the lower limbs. Clear?
Yes, sir.
Okay. So what you will do, you will do splinting only for
Splinting
the
only.
limbs. Splinting,
Yes.
whatever by back slab, or if you have ortho team, okay? So you are doing resuscitation and the ortho team is doing splinting, not your issue now, right?
Yes, sir.
Okay. Whatever, sometimes you will do splinting by carton. Clear?
Mhm.
It's
Yes,
not
sir.
our issue now. Just to mention a splinting of the deformity in the long bones. More than enough. Okay.
Mhm.
Regarding the pelvis, apply pelvic binder first. So the priority,
Mhm.
pelvis. Don't comment on
Mhm.
the deformity in the lower limbs. So number one, of course, you will verbalize the findings, then call the team, then do the intervention. Intervention, it will be non-pharmacological for the pelvis, non-pharmacological for the limbs, and then you will do pharmacological. What does it mean pharmacological? You will give the patient, insert two IV access, extract the blood for blah, 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 blah. Give the patient blood transfusion and the painkiller. Easy?
Yes, sir.
This is the pharmacological. Blood transfusion, analgesia. I
Mhm.
wish it's clear. Don't
Yes.
ask about blood pressure in the first C. You will ask one
Yes.
time in the first C, then give the treatment, then go for D, disability. In the second C, I want you to stop, okay?
Mhm.
So you will stick in the second C. Okay,
Yes, sir.
well done. You have 30 seconds and 6 minutes.
Dr. Hani, do we need to mention about angioembolization for pelvis?
Yes, okay. So here I need fast for what any free fluid collection in the pelvic area and other views, right? Okay. Then you will say the patient has hypotension. It could be hypovolemic hemorrhagic shock because of bleeding in the pelvic area or bleeding from the pelvis from, if you are not sure about the names, you can say from arteries and the veins in the pelvis. Easy.
Okay, sir.
Veins, it means venous plexus. Arteries, it means internal iliac arteries. Easy.
Yes, sir.
What if you don't know the names? No problem. You can say arteries or you can say vessels in the pelvis. More than enough. Clear?
Yes, sir.
So in liver, you will say liver injury. Spleen, you will say spleen injury. But here in pelvis, you will say pelvic injury, pelvic vessels injury. Clear?
Yes, sir.
Okay. So what is the first priority? Orthopedic or vascular? Orthopedic. Okay.
Orthopedic.
So the basic orthopedic, they can do the needful. If they cannot stop the bleeding in theater, they will call vascular. They can do interventional radiology. Clear?
Okay, sir.
It's not our issue.
Hmm.
Your issue is basic. Easy?
Yes, sir.
Okay. So they can do immobilization if the bleeding is not stopped in the theater. Not our issue. This between the orthopedic and other team. Clear?
Yes, sir.
Okay, you have 30 seconds and 6 minutes.
Good morning. I'm Dr. Sundar CD Registrar. May I know your name and level, please? Are you happy to take care of airway and breathing and you with circulation? We are about to receive a patient with trauma, so we need to prepare ourselves. Patient arrive.
Patient arrived.
Any handover from ambulance crew?
Yeah, this patient, we extracted him from the car, road traffic accident, and he has pelvic injury.
Thank you so much. Going to the patient, staff, can you please activate trauma call? I'm maintaining inline stabilization. Is the patient conscious?
Unconscious.
Patient is unconscious. Look, listen, and feel there's sign of life.
Yes.
Okay. So is airway patent?
Airway is patent.
Okay. Staff, please attach high flow oxygen with non-rebreather mask. Expose chest and attach all monitors. I want to know SpO2, respiratory rate, trachea, neck veins, chest inspection, palpation, percussion, auscultation. Going to circulation, I want to know BP, pulse, CRT, peripheral pulses. Exposed abdomen, I want to inspect, palpate, percuss, and auscultate the abdomen.
The blood pressure is not recordable, and the abdomen inspection, the patient has pelvic contusions and the tenderness in the pelvic area. Pelvis is unstable.
Okay. And any long bone deformity, any free fluid on EFAST?
Deformity in the right side and deformity in the left leg.
Okay. Staff, please, you mentioned that there is no PP, but is there a sign of life?
Yes.
Maintain large IV bore cannula, 2 large IV bore cannula, draw samples for blood count, cross-match coagulation profile. And can we get a same blood group blood as well, 4 pack cells, and start it in bolus. Now I want to know the GCS of this patient, pupils, and also, sorry, the pelvis was unstable. I want to apply a pelvic binder and only apply so pelvis is unstable. That means we have an injury in pelvis. We need to apply pelvic binder and only a splint of the lower limb, and also call orthopedic team for further assistance. Now I want to know the GCS, pupils, any signs of lateralization and blood sugar.
Normal.
On exposure, any active bleeding for any extremity, and temperature. Okay, have we got a blood? So going again on patient, is the patient responsive? Is the airway still patent? I want to know the BP. We have started blood. Is there an improvement?
The blood pressure is still low.
Blood pressure is too low. So we have started the 4-pack cells. Do we have any results? Blood results?
We have no blood results at the moment.
Okay, so we can the BP is still low. The patient is in hypovolemic hemorrhagic shock because of the pelvis. So we need to give the first primary pack, which contain 4-pack cells, 4-pack cells, 4 FFPs, and 1 platelet. Meanwhile, we need to ask for OR and our teams to be ready.
They are busy,
Then
doctor.
okay, no problem. We can reassess the patient. Is the BP any improvement?
Still low.
Okay. Do we have any results?
Yes, we have results now.
Okay. What's the HB?
Hemoglobin is 5.
Okay. So we need to give 4 pack cells. Do we have a INR?
INR is 3.
Okay. So we need to give 4 FFPs. And do we have a platelets?
Platelets 20,000.
Okay. So we need to give 1 unit of platelet. And do we have a fibrinogen level?
Fibrinogen is 1.
Okay, so we need to give cryos as well. Is OR ready? Is team still available or any special
They
orthopedic
are
team
busy. They
available?
have 3 patients
Okay,
in theater.
okay. Okay, so we will reassess the patient. Again, is there any improvement with our BP, blood pressure?
Still low.
Okay, so we can give the 3rd pack, again the secondary pack. We can repeat the secondary pack. We
The
can
blood
also give
pressure is
2
still
gram
low.
of. Okay, so we can give 2 gram of transamine as well, and we have already doing the pelvic binding, and
Blood pressure is still low.
um, we have still low. We have given. We can continue our blood and we can arrange angioembolization, and we can ask
The
radiology
theater
to
is
take.
busy. The blood pressure is still low.
Okay. Uh, we can continue the blood transfusion
Okay,
because
thank you,
it
doctor.
will take. Thank you, sir.
Okay. How many marks, guys, for Sundos? Of course, 10. Okay. So here is a patient, if the blood pressure is still low. Regarding tranexamic acid, you can give for any trauma, any hemorrhagic shock.
Yeah. Yes, sir.
Okay. Um, Even if no hemorrhagic shock, yes, no problem. I mean, for example, the patient has head injury and he has blah, blah, blah. It's not important in head injury because,
Mhm.
for example, the patient in head injury, he lost, for example, maybe 50 ml or 100 ml blood in the brain. This cause compression on the brain, and that's why the patient has hypotension. So, tranexamic acid here is not the main issue now, right? Okay, but you can give, yes, you can give. Okay, so tranexamic acid better in any major hemorrhage. What does it mean, major hemorrhage? Major hemorrhage doesn't mean massive blood loss. No, the difference between massive blood loss and the major hemorrhage is big. So massive blood loss, the amount of blood. But major hemorrhage, it means even hemorrhage inside closed space. What does it mean? The skull is closed space, right?
Yes, sir.
It means any bleeding inside the skull, it means a major hemorrhage. Any bleeding inside the eye, it means a major hemorrhage. Any bleeding inside the chest, it means a major hemorrhage. Any bleeding inside the abdomen, major hemorrhage. Any bleeding inside the joint, major hemorrhage. Any bleeding inside the limb is called major hemorrhage, even if the amount of blood loss not massive. Clear, guys, this point?
Yes, sir.
So if I say in major hemorrhage doesn't mean massive blood loss. I wish it's clear. Okay. So major hemorrhage, it's sometimes life-saving, sometimes limb-saving, sometimes both. For example, in the eye, is it life-saving or organ-saving?
Organ
Organ saving.
saving.
Organ-saving, if the patient lost
Yeah.
his eyes, he will be alive, right?
Mm. Mm.
But in the
Yes.
brain, it's both life-saving and organ-saving. So if you save the brain, you will save the life. Because if no brain, no um, no centers for the heart and breathing. So the patient will go in cardiac arrest. Okay. So it's not our issue now. So you did well. So you can follow the same approach. So here, regarding the massive transfusion protocol you followed, all points 100% accuracy, and regarding skillfulness, very fluent. Regarding efficiency structure, very organized, and supportiveness, you are doing very well, explaining everything. Safety, correct information. So I will give you 10 out of 10. Thank you, Sandos.
Dr. Hani, if in exam they do the same, like the patient is not improving, but you are doing all right things, so you keep on continuing your task. Like for example, if team is not available, you are giving blood, you are doing everything, so you can continue doing the same.
Yes, do the same. Okay.
Mm.
So here, 4 units back the RBCs, it will take like 1 hour. It's not logic to be
Yeah.
like that in
Yeah.
the real practice. Okay.
Yes,
If you
sir.
will give the
Yes.
primary back, it will take like 1 hour. Secondary back,
Mm.
1 hour. Do you think the surgery team will stay for 1 hour, 2 hours, 3 hours, 4 hours? Not logic.
No, no.
Okay?
Mm.
But the
Okay.
point is, you can save the life even the surgery team is not available at the moment. It means you
Mm.
can refer the patient to any near center. Clear?
Mm. Mm. Yes, sir.
You
Clear.
can refer the
Thank you.
patient to any near center. Okay. So
Okay.
don't worry, guys. If you have any serious patient in the emergency room, you can save with blood transfusion, but do the needful for the patient. Okay.
Mhm.
Okay.
Yes.
Next one, Ike.
Thank you.
Welcome. Ike.
Yeah, yes, I'm here.
This station the same. Okay. So here bilateral lower limbs amputation. Um, After handover, you will go behind the head. You will say CABCD. So you can say, please nurse control any major hemorrhage. Clear?
Yes, sir.
So control the hemorrhage of amputation by direct dressing compression and ignore hair. Don't ask hair controlled or not. Easy.
Okay. Yes, sir.
Then go for airway, breathing, circulation as usual. In circulation, you will ask about the 9 points.
Okay.
One of them, long bones again, number 8, right?
Yeah.
Right,
Yes, sir.
doctor?
Yes, sir.
Okay. So you will ask about long bones again. Any deformity, the patient has amputation. So ask about the site of amputation and ask if the bleeding controlled or not. If the bleeding controlled, ignore. Go ahead. If the bleeding is still bleeding, then you can control by
Like
tourniquet.
this one?
Tourniquet.
Something, okay.
So you can apply tourniquet in the affected limb or the limb which is still bleeding. It will
Okay.
be above the amputation point. Easy?
Yes, sir.
Okay. So same as before. In circulation, you will call trauma team or orthopedic team and activate massive transfusion protocol and call a prepare setter. Okay.
Yes, sir.
Then this patient needs surgery for the amputated parts. Clear?
Yeah.
Okay. Then what you will do now, insert the two IV access, extract the blood for blah, 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 and give 4 units back the RBCs. Clear?
Yes, sir.
Okay. You have 30 seconds and 6 minutes.
All right, sir. Can I start?
Yes, please.
Hello, my name is Ike. I'm one of the A&E registrars, and I'll be the trauma leader today. Can I just confirm your name, your grade, and your competency, please?
Patient arrived.
Our patient arrived. Is the patient conscious?
Take hand over from
Can I
ambulance.
get some handover, please? Can I get handover, please?
Yeah, this patient we extracted from the car. Unfortunately, he has amputation lower limbs.
Okay. Nurse, let us please control any major hemorrhage and maintain manual inline stabilization. Is the patient conscious?
The patient is unconscious.
Look, listen, and feel any signs of life?
The patient has signs of life.
Okay. And airway?
Airway
patent?
Airway is patent.
Okay. Let us apply cervical collar and put in an OPA and give high flow oxygen. And then we'll move to breathing. What is the respiratory rate, the saturation, the trachea, the neck veins, inspection, palpation, percussion, and auscultation?
Normal.
Okay. Circulation, blood pressure, heart rate, peripheral pulses, and HR, the heart rate. Okay. What about abdominals? Okay. So the patient has sinus tachycardia. That could be signs of hemorrhage. What of the blood pressure?
The blood pressure is not recordable.
Look, listen, and feel any signs of life?
Yes.
Okay. What about the CRT?
You ask already, doctor, and you continue other
Okay.
points.
All right. Let's establish 2 IV access with white
Ask
box
about
cannulas.
other points, doctor. You have 9 points.
Okay. Abdominal inspection and palpation.
Abdomen inspection normal, palpation normal.
Okay. Is the pelvic stable?
Yes.
All right. What about the long bones? We know there is amputation. Can I just confirm the site?
Yes, amputation in the right lower limb above the ankle, and the amputation in the lower limb above the knee.
All right. Thank you very much. We did try to control hemorrhage earlier. Is the site still bleeding? Okay. All right. Let us
In the
apply.
right side is still bleeding.
Okay. So it seems the left side is controlled. Now let us apply tourniquet on the right side that's still bleeding. All right, and let us establish IV access with white box cannulas and take bloods for grouping and cross matching, hematology, biochemistry, coagulation studies. Let us activate the major hemorrhage protocol, activate the trauma team, the orthopedic team as well, and let us give 4 units of packed red blood cells. Okay, and what about the GCS?
GCS is 9.
Okay, there is reduced GCS. Any signs of lateralization? What are the pupils doing and the blood sugar?
Blood sugar is 5.
Okay, what about the pupils?
Equireactive.
Okay, very good. Exposing this patient now, seeing that there are other injuries, is there any midline C-spine tenderness? Are there any other abnormalities? Okay, what about the temperature? Okay, all right. So now I'd like to hand over to the team, but not sure if they are here. We need to reassess the patient. Is the patient still conscious?
The patient was not conscious.
Okay. Is the airway patent?
The airway is patent.
Okay. What about the respiratory rate, the saturations, the neck veins, inspection, palpation, percussion, and auscultation?
Normal.
Okay. For the circulation, what about the blood pressure?
Still low.
Okay. Respiratory rate. Heart rate.
In the second assessment, ask about brief. 1 point only, more than enough.
Okay. In the second assessment. Okay. All right. So can we get Do we have blood result for circulation for the blood that we took earlier?
No, no blood results at the moment.
Okay, and the blood pressure is still low. All right, so let's give the primary pack now. Let's give four units of packed red blood cells. Let us give 4 units of fresh frozen plasma and 1 unit of platelet.
Blood
Okay,
pressure is still low.
all right. We will reassess the patient. Is the patient still unconscious?
I ask you, blood pressure is still low, so stay in C.
Okay, so blood pressure is still low even after giving primary pack. Now let us give secondary pack. Now we're going to give 4 units of packed red blood cells, 4 units of fresh frozen plasma, 1 unit of platelet, and 2 poles of cryoprecipitate.
Blood pressure is still low.
Okay, do we have blood result now?
What do you need?
HB.
5.
Okay, HB is 5. What about the INR?
3.
Okay, what about the platelet?
20,000.
Okay, and the fibrinogen?
1.
Okay, so all 4 lines of hematology are low, so we're going to give another secondary pack, 4 units of packed red blood cells, 4 units of fresh frozen plasma, 1 unit of platelet, and 2 more pools of cryoprecipitate, and then
Okay,
we
thank
assess.
you. Thank you, Ike. Okay, well done. Thank you.
Thank
You
you very
did
much.
very well. So here you have in the first assessment should be full assessment, full finding, full call, full interview. It means in full assessment, ask about all points. But in brief assessment, second assessment, 1 point only. Clear?
Okay, yes, sir.
So in breathing, in the first assessment, you will ask about 8 points. In the second assessment, SpO2 only more than enough. Clear?
Okay, yes, yes, sir.
And the other abnormalities, if important, for example, tension pneumothorax. So in second assessment, you will ask about SpO2, you will ask about trachea because you want to see if it's still central or not. Easy. You
Yes,
will
sir.
ask about percussion to see if it's still resonant after chest drain. Did you get my point?
Yes, sir. Yes, sir. Yes, sir.
So here you found all breathing points normal. So you are expecting everything will be normal, same. Because the problem not in breathing now, right?
Yes, sir.
Okay. So in circulation, you should ask about 9 points. We said full assessment. Full assessment, it means 9 points. Don't ask about, for example, 4 points and stop. No, ask about the 9 points. Even if you will ask about 4 points and I answered you, then continue from 5 to 9. Clear, doctor?
Yes, sir.
Okay. So here you ask the nurse control major hemorrhage. Okay.
Yes, sir.
But you did not advise here what to do. Clear?
Yeah.
It's like, for example, you found problem in airway. You ask the nurse control the airway. Is it logic?
No, sir.
Is it logic?
No, sir.
No. So control the major hemorrhage. You can tell here the patient has lower limb amputation. Apply direct pressure
Pressure.
by dressing. Easy.
Yes, sir.
So if you did not mention the action, no benefit, right?
Yes, sir.
Maybe she will control by anything. Okay. No. So you finished this one. Then in airway, you did well. In breathing, done. Circulation, done. So you will call the trauma team, orthopedic, and activate massive transfusion protocol. Then prepare theater. Then intervention, 32 IV access, extract blood for hematology, blood culture, blah, 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 blah. Corban safe, cross match, and give the patient 4 units back the RBCs. Excellent. In the second C, I want you to stop in the second C. So you ask about blood results, no blood results. That's why you give the patient primary back. Excellent. Okay. In the next circulation, you find the blood pressure is still low, but you did not ask about blood results. So you give blind. You did not ask about blood result. Clear? Okay.
Yes, sir.
So before any primary back or before any secondary back, you should ask about blood results first. Clear? This
Yes,
is the
sir.
only missed point from you. Otherwise, you did very well. Thank you.
Thank you.
So I will give you 8 out of 10. Thank you.
Thank you very much.
Well done. Next one.
Dr. Hani, please, I have a question.
Yes.
Like a patient with this hemorrhage and my patient is hypotensive, is it advisable to use a warm packed RBC or warm blood transfusion?
You use what?
Like during my case, the patient was hypotensive, temperature of 34. Is it
Okay.
advisable to say warm blood transfusion?
One blood transfusion?
Warm.
Warm.
Yeah, since the patient is hypotensive.
Yes, you can say warm blood transfusion, no problem.
Okay.
Yes. Here also one point, guys. If you want to start 4 units back the RBCs only, accepted. If you want to start 4 units back the RBCs, 4 units fresh frozen plasma, 1 unit platelet in the first circulation, also accepted. Clear this point, guys?
Yes, sir.
Yeah.
In the first circulation, according to ATLS 11th edition, you can start 4-4-1. It means 4 units back the RBCs, 4 units fresh frozen plasma, 1 unit platelet. In the first circulation, yes. Okay. And in the second circulation, you will check blood results and correct according to the abnormalities. In the third circulation, you can correct the abnormalities also. Okay. So why I said 4 units back the RBCs only? Because back the RBCs only more than enough to stop any bleeding, whatever traumatic or non-traumatic. And again, you can give tranexamic acid in any major hemorrhage. Okay. Next one, Sondos.
Yes, sir.
Okay, this is the last station. So major burn. Okay. So
Yes.
explosion at house. Explosion, what does it mean?
Sir, maybe stove or something. Blast.
Explosion, it means heavy and high energy, right?
Yes, sir.
It means you are expecting trauma. You are expecting injuries to the head, chest, abdomen, pelvis, limbs. Clear?
Yes, sir.
What else? Explosion, it means inhalational injury, right?
Yes, sir.
So if the patient airway normal, no burn in the head or neck, but the patient has explosion, it means inhalational injury until proven otherwise. Clear?
Yes, sir.
So the term explosion, it means inhalational injury until proven otherwise. Okay. So this station, same as other stations. What is the difference? Burn. It means in airway, you will mention burn. In breathing, you will mention burn. In circulation, you will mention burn. In disability, you will mention burn. This is the only modification. Easy? So, in assessment, you will say manual inline stabilization. Is the patient conscious? Then, is the airway patent? Then you will ask any burn in the head or neck. Easy? Done. In breathing, expose the chest, connect all monitors. What about blah 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 blah? Once you reach inspection, what about inspection? Any
Burn to chest.
burn. Any burn. Okay. Then in circulation, you will ask about 9 points. Once you reach inspection, you will ask what about abdomen inspection? Any
Burn.
burn. If you reach pelvis, is the pelvis stable? Any
Burn.
if you ask about long bones, any deformity? Any
Burn.
burn. Easy.
Yes, sir.
Expose all the body. Any other abnormality? What about temperature? I will calculate body surface area. Clear?
Yes, sir.
So in exposure, you will add, I will calculate body surface area. Done. So if you find in circulation the blood pressure is low, is it fluid loss? Unlikely. Patient has hypotension. Is it fluid loss? Unlikely. So it could be hemorrhage. Okay. So you can say it could be hemorrhage. How to differentiate? Fast. So if fast positive, what is the cause?
Hemorrhage.
hemorrhage, blood loss. If fast negative, it means a fluid loss. Easy?
Yes, sir.
Okay. So if fast positive in the right upper quadrant, it means hemorrhagic blood loss. It means hypovolemic hemorrhagic shock. Okay. From liver injury. This patient needs emergency laparotomy, right?
Yes. Yes, sir.
So the station not about major burn. The patient can die from the burn, can die from hemorrhage. So you are doing the needful for burn and you are doing the needful for the blood loss. Okay?
Yes,
Okay.
sir.
If the patient has hypothermia, what you will do?
Sir, active and passive rewarming.
No. I am against this one,
Co
guys.
cover
Wait,
the.
please. Wait, please. I am against avoid hypothermia in burn. Why the patient? Why the patient before burn has normal temperature? Why after burn has hypothermia? Why? Is it good or bad?
Sir, body cooling is like natural.
Why the patient has burn? Because of temperature, high temperature or low temperature?
High temperature.
High temperature. Why the patient got the burn? Because of high
High
temperature,
temp.
right?
Yes,
You will increase the temperature or decrease the temperature for this patient?
sir, decrease.
Decrease. So if the patient temperature 34, is it good or bad?
Good.
Good.
Bad.
Good. Why bad? Okay. I will tell you something. If the patient has temperature, different station or different case in real practice or in the exam, if the patient has high temperature, why the patient has high temperature in general?
Sir,
Why?
maybe infection, body
No,
response to an
no,
infection.
no, 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 no. Why Allah created us like that? If we have temperature, high temperature, it could be infection, one of the million reasons, okay? But maybe hypoxia,
Yes.
maybe acidosis,
Mm-hmm.
maybe limb ischemia, maybe DVT, maybe pulmonary embolism. Why? The hemoglobin carry oxygen. The hemoglobin carry oxygen. The hemoglobin deliver this oxygen to the tissue, deliver to the heart, deliver to the brain, deliver to the kidneys, to the liver, to the muscles. So if the patient has normal oxygen, the hemoglobin will keep carrying the oxygen and do not deliver this because the oxygen is normal, right?
Yes, sir.
Once the oxygen will decrease, once the oxygen will decrease, the hemoglobin will be in a hurry to deliver the oxygen to tissue because of hypoxia. Easy? How the hemoglobin delivers the oxygen? By increasing the temperature. If the temperature increase, then the hemoglobin delivers this oxygen to the tissue. Easy?
Yes, sir.
So, if the patient has pulmonary embolism, has hypoxia or not?
Hypoxia.
Yes, sir.
Has hypoxia. The hemoglobin carries the oxygen. I want this hemoglobin to deliver this oxygen in the blood to the lungs. But unfortunately, there is blood clot in the lung artery, the pulmonary artery. So the temperature of the patient will increase. So the temperature of the pulmonary embolism increased because of infection or because of hypoxia?
Hypoxia.
Hypoxia, because you want to deliver this oxygen to the tissue. Easy?
Yes,
Yeah.
sir.
The patient has DVT. The patient has DVT. It means blood clot in the vein in the leg. This patient has hypoxia in the lung or hypoxia in the leg?
Hypoxia in the leg.
In the leg. And the hemoglobin carries the oxygen. I want this hemoglobin to deliver this oxygen to the tissue, to the muscle of the leg. So I will increase
Temperature.
temperature. That's why the patient with pulmonary embolism has mild temperature. That's why the patient with DVT has mild temperature. Clear now?
Yes.
Thank you.
Is it logic to decrease the temperature of the patient?
Mm-hmm. No.
Is it logic? Patient has pulmonary
No.
embolism and has mild temperature. Is it logic to decrease his temperature?
No.
No.
No, sir.
Allah created us like that to help us. The temperature increase delivering of hemoglobin with oxygen to the tissue. Which tissue? With hypoxia. The lung, pulmonary embolism with hypoxia, so you will deliver more oxygen to the hypoxic area. Deliver the oxygen in DVT to the leg because this area hypoxic. Easy, guys?
Yes, sir.
Okay. If the patient has temperature 41, is it good or bad? Bad. Patient has patient is making exercise. Patient making exercise, running like marathon. He needs oxygen or not?
Needs.
He needs oxygen. He needs blood sugar or not? I mean dextrose. Yes. If the patient is running in marathon, he needs oxygen, he needs glucose. That's why the patient making exercise, hemoglobin carry oxygen, carry glucose. If hemoglobin find the patient or the person, normal person, because he's still not patient now, the hemoglobin carries the oxygen and dextrose. Once the person is running, the dextrose or the blood glucose rise in the body. For example, 600, 800. Is it serious?
No.
No. The saturation will increase because the hemoglobin carry more oxygen. Is it serious? No. How you will deliver oxygen and glucose to the tissue when the person runs? By increasing the temperature, right? When you
Yes.
increase the temperature, the hemoglobin will give more oxygen and more blood glucose to the tissue. Why? Because the patient is doing exercise, but within limit. This is called compensation. What if the patient or the person is running for 2 kilometers? Okay. 5 kilometers? Okay. 10 kilometers? Okay. With limit. After this limit, the temperature will increase uncontrolled, like 40 or 41 or 43. The patient has heat stroke. Why? Because the body cannot compensate anymore. Increase the more temperature because you are running, and you need more oxygen, more dextrose. That's why the body cannot compensate anymore. So when you decrease the temperature from 41 or 42, you will decrease to 38 or you will decrease to 37 or to 36. Which is better?
Moderate decrease.
38. 38. Okay. So any patient has hyperthermia or fever, when you decrease the temperature, don't decrease very low. Clear, guys?
Yes, sir.
Because you need the temperature. So patient has infection, whatever bacteria or virus, and the temperature is 39.5. You will decrease to 38 or to 36.
38.
38. Clear now?
Yes.
Who increased the temperature? This compensation, normal compensation. Okay. So if you will decrease the temperature to 36, the oxygen will be difficult to be delivered to the tissue. The dextrose carried with the hemoglobin will be difficult to reach the tissue. Easy, guys?
Yes, sir.
So when you control the temperature, control to limit at least 37.8, but not very low. Clear now? I wish
Yes,
it's
sir.
clear. The same idea. Patient was normal. After explosion, he has major burn everywhere in his body. His temperature became 33. What is the reason? You are expecting after burn the temperature will be high. No, the temperature became low. This is compensation from the body, right?
Mm-hmm. Yes, sir.
That what is the first intervention for any burn? For example, baby, he has burn in the upper limb. The baby is conscious.
Mm-hmm.
What to do? You will put in water for 20 minutes, cold water, okay? Or you will move this baby with the car to the hospital with 30 minutes, okay?
Sir, water first.
If you will put in cold water, you will protect the arm. So the
Yes,
heat will not eat the arm, right?
yes, sir.
So not logic to move the baby to the hospital for 30 minutes and the heat is eating the arm, right?
Yes,
The same idea. When the patient get any explosion or any major burn, the body is trying to make the temperature low. Why low? It's like you are putting the body in cold water. Did you get my point?
yes, sir.
So this is normal compensation. Is it logic? Is it logic if you find the father putting the arm in cold water, you will make the cold water hot?
No, sir.
No. To say, for example, avoid hypothermia? No. So patient with burn, don't don't increase his temperature. Easy.
Okay.
Avoid hypothermia, but don't increase the temperature. I wish it's clear. So you can say avoid hypothermia. What does it mean, avoid hypothermia? When the patient in marathon running and his temperature became 42, try to decrease to accepted, for example, to 38. The same idea, if the temperature of major burn decreased to, for example, 30, you can increase to, for example, 34, but don't increase to 37 or 39, right?
Yes, sir.
This is my idea. Okay. Anyway, this for real practice, guys. I want you to be strong and professional doctors in real practice. It's not about do actions without understanding. Okay. So anyway, here in airway, you will ask after is the patient conscious? Is the airway patent? You will ask any burn in the head or neck. In breathing, any burn in the chest, anterior and
Yes.
posterior aspects. In circulation, you will ask any burn in the
Burns
abdomen, any
on
burn in
abdomen.
the pelvis, any burn in the long bones. And in exposure, you will ask, I will calculate body surface area. Clear? Okay. What is the
Yes.
intervention here? In airway, you will say the patient has patent airway, but he was in explosion, so my concern is inhalational injury. Easy?
Yes, sir.
What if the examiner said the airway is not patent, the patient has burn in the lips, so it means inhalational injury also. Okay,
Mm.
so call trauma team, including anesthetist. This patient needs early intubation. Okay, what does it
Mm.
mean early intubation? Is it emergency or urgency?
Urgency.
Urgency, so no need to intubate now. If emergency,
Mm.
you will say call
You
anesthetist to
will
intubate
intubate.
the patient intubated, connected to back valve mask, one ventilation, every blah 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 blah. Clear, Santos?
Yes, sir.
Okay, so here regarding this patient in breathing, you will say the restricted chest rise in an inspection and palpation and hypoxia. The trachea is normal, neck veins normal. It means circumferential burn, and the patient has burn anterior posterior aspects. So call this patient already has circumferential burn. So call surgery team. This patient needs
Hysterotomy.
Emergency sclerotomy. Emergency. What does it
Okay.
mean, emergency? Should be
Now.
done now. Done by
Yes.
surgery team. If you say call surgery team, this patient needs a sclerotomy, and the nurse is silent, it means done.
Mm.
If the nurse said surgery team not available, it means you should do. Clear?
Yes, sir. Yes.
So how to do? You should say two horizontal lines, right?
Mm.
And two vertical lines. How to do
Mm.
horizontal lines? So here you have two lines horizontal and two lines vertical. Horizontal, it means
Mm.
parallel to the clavicle and parallel to the costo.
Subcostal region.
Okay. And the vertical parallel to the nipples. Clear?
Yes.
Done. But you should check success. It means
Mm.
you have hypoxia and restricted chest rise before sclerotomy. Confirm improved or not. So what about SpO2? What about chest rise in inspection and in palpation? So improved, right?
Okay.
It means successful. Then you will go for C. You will find the patient has burn in the anterior aspect of abdomen. Then because of the burn, you don't know the patient has contusions or not, right? Because the burn
Mm.
mask abrasions, contusions, and injuries. And also the burn masks the tenderness. You don't know this tenderness because of the burn or because of liver injury or spleen injury or any
Mm-hmm.
injury in the abdomen, right?
Right, sir.
That's why you should do
Do
fast.
fast. Fast.
Fast here will give you clear idea. Excellent. Then long bones. If you find circumferential burn in any limb, is it emergency or urgency?
Emergency.
No, urgency.
Okay.
So in the chest, emergency because A, B, C, D. But in the
Mm-hmm.
limb, it's a limb saving, not life saving. Chest is life saving.
Life
Limb
saving.
is limb saving. Clear, doctor?
Mm. Yes, sir.
So in chest, you will say call surgery team to do emergency sclerotomy. In limb, you will say call surgery team to do urgent sclerotomy. Easy.
Yes, sir.
In chest, if they said surgery team not available, you will do. In limb, if
Mm.
they said surgery team not available, don't do. Clear?
Mm. Yes, sir.
Can be done after 1 hour, after 2 hours, don't worry. Okay? But chest, no.
Mm.
He will die within few minutes if you will not do sclerotomy. Clear?
Yes, sir.
Okay, then exposure. Once you go for exposure, you will say, I will calculate body surface area. Just to mention the points of burn. For example, I said burn in the lips. I said burn in the chest anterior posterior. I said burn in the abdomen anterior aspect. I said burn in the upper limb circumferential. Then in exposure, you can say, I will calculate body surface area. The patient has burn in the lips plus chest anterior posterior aspects plus anterior aspect of the abdomen and upper limbs circumferential means anterior posterior. Then you can say I will calculate Barkland formula.
Body, sir. Mm.
Barkland formula. How Barkland formula? Any patient with inhalational injury like this patient, it will be 4 ml per body surface area per kilogram. But you will
Yes,
start after blood transfusion because
yes,
fluid here contraindicated. Easy.
yes, sir.
The priority blood transfusion now. Clear?
Yes, sir.
Okay. So you will call surgery team, activate massive transfusion protocol, and the theater also because the patient has maybe liver injury, maybe spleen injury, maybe pelvic injury, maybe pelvis is unstable also. Maybe the examiner can give you
Mm.
anything. Easy?
Mm. Mm.
Okay,
Yes,
you
sir.
have 30 seconds and 6 minutes.
Sir, can we start first blood if the abdomen findings are positive in first circulation we can start the blood.
In the first C, you will if the patient has positive fast, you will start
Yes.
4 units back the RBCs and the
Okay.
tranexamic
Yes.
acid. Clear?
Yes. Yes, sir.
Okay. You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Sundar, CD Registrar. May I know your name and level, please? We are expecting a patient with burns, so we need to prepare airway trolley and difficult airway trolley as well. And we need to have a resuscitative drugs also. Patient arrived. Do we have a handover from ambulance crew?
Yes, the patient has explosion in his house. We extracted the patient from the second floor.
Mhm. Thank you so much. Activate staff. So we have this patient activate a trauma team and also maintain inline stabilization. Is the patient conscious?
The patient
Is
is
the
unconscious.
airway patent?
Not patent. The patient has a stridor, hoarseness of voice, and
Okay.
snoring, no secretions.
Okay. So patient is having hoarseness of voice and stridor. We can do jaw thrust and will apply high flow oxygen to this patient. This patient has a threatened airway, and we need to call anesthesia as he is having inhalation injury, and we need early intubation. Also, staff, you will prepare difficult airway trolley as well. Exposed chest, attach monitors, and may I know the SpO2, respiratory rate, trachea, neck veins, chest inspection, palpation, percussion, and auscultation? Am I able to appreciate any burn?
Yes, the patient has SpO2 80 and the tracheocentral neck veins normal, inspection burn in the anterior and posterior aspects, and restricted chest rise on inspection and palpation. Normal air entries.
Okay. So staff, yes, this is circumferential burn or to the chest as well. So we need to do urgent emergency sclerotomy. We need to inform surgery team to
Not
do that.
available.
Okay, so we will do this by ourselves to resume the breathing component. So we need a scalpel, and so we will perform this sclerotomy by two horizontal and two vertical lines. Horizontal lines will be one from the parallel to clavicle and one parallel to subcostal region, while the vertical will be from the both nipples. Is sclerotomy done? I'm looking for the how much improvement in chest expansion,
Improving now.
and SpO2 is also improving.
Yes.
Okay, so now we are moving towards circulation. We need to know BP and heart rate, CRT, peripheral pulses. Expose the abdomen, and I want to know on inspection, palpation, percussion, auscultation, if there is any burn on inspection.
The patient
I need to
has.
see.
Yes, continue, please.
Sorry. I want to also see the pelvic. Is it stable? Is there any burns on pelvis or also on long bone? Are there any long bone burns? And also I want to do E first for any free fluid in a abdomen and pelvis.
Okay, the blood pressure is low and the patient has burn anterior aspects. He has tenderness in the abdomen and pelvis is stable. Long bones are normal, no deformity, but he has upper limbs circumferential burn and the fast is positive in the right upper quadrant.
Okay, so this patient is having both hypovolemic hemorrhagic shock. So we need to get a two large bore IV cannula. Staff, please collect samples from for blood count, cross match, coagulation profile, and arrange blood as well. We need to transfuse this patient for PEG cells cross match. And we need to also cover all these burns. And the E-fast is positive, so we need urgent surgery consultation to take this patient to OR. Next, how's the GCS, pupils, any signs of lateralization and blood sugar?
Normal.
And now I am exposing the patient. We already mentioned that we have a burns on upper extremities, upper side of lower extremities, and how's the temperature? I will now calculate body surface area for burns, and as we have assessed the patient, the burns include the face and upper face and the whole circumferential chest, only anterior part of abdomen or and the lower limb, upper side circumferential burn. So we will calculate body surface area. And with Parkland formula, we will give fluid after transfusing blood. May I know, I want to hand over this patient to the relevant specialty and will reassess the patient. Is anesthesia right for airway? Okay, I want to know the BP of this patient. We have already done hysterotomy. Is the breathing still good?
Okay, thank you, doctor. Thank you.
Thank you.
Okay, your time done. Well done. You missed to ask about any burn in the head and the neck, right?
Yes, sir.
Okay, and you did well. You called the trauma team, including anesthetist, to intubate this patient, early intubation. Okay, in chest, you did well. So you will do surgical wounds. I want you to mention surgical wounds. Clear? So
Okay, sir.
this call surgery team to do sclerotomy, emergency sclerotomy. Okay. If he said not available, okay, nurse, please give me a scalpel. I will do surgical wounds. So you will do
Okay.
4 surgical wounds, 2 horizontal, 2 vertical, done. And then you confirm the success, done. And it was successful. In circulation, you find the patient has positive fast and hypotension. So this patient needs emergency laparotomy. You can call the trauma team, surgery team, activate massive transfusion protocol, and theater. Excellent. Okay. Then regarding the upper limbs, circumferential burn, so he needs urgent sclerotomy. Okay, well done. Well done. Okay. So here in the end, you calculated both surface area and the Barkland formula, and you will start them after the blood transfusion. So half of them in the first 8 hours. I'm talking about Barkland formula, and
Yes,
half of them over the next 16 hours. Excellent.
16 hours.
Yes. So in such a patient, you said I will hand over to relevant specialty. This between me and you, but what does it mean
Yes, sir.
relevant specialty?
I will
So,
hand over to surgery.
okay, so you can say patient intubated, after handover, patient intubated, connected to back valve mask, and one ventilation every 6 seconds. Then you will check the 4 points of success of the tube. Clear? So
Okay.
in reassessment, you will optimize the approach, optimize intubation. In sclerotomy, you will confirm the 3 points again. What about SpO2? What about chest rise? Easy.
Yes, sir.
In circulation, you will check the blood pressure. You will find still low. So you started already 4 units back the RBCs and the tranexamic acid in first circulation. In second circulation, you will start the primary pack, then the secondary pack. Okay.
Yes, sir.
Here regarding handover to whom? Trauma team.
Hmm.
What else? Surgery team. And this patient, after surgery team, we will transfer to which unit?
Burn or
Burn
ICU.
unit. Okay. Or burn center. Easy.
Yes,
Which is priority? Intubation or surgery or burn center?
intubation,
Intubation. After intubation, surgery. After
surgery,
surgery, burn center. Easy.
burn unit. Yes, sir.
A is the first killer. C is the third killer. I'm talking about surgery. And burn, this is exposure. It means is
Mhm.
the last killer. Clear?
Yes,
So you will intubate the patient because surgery, any patient with surgery, intubation. Okay? And then you will refer to burn center after successful surgery. Easy?
Yes, sir.
Okay. So I will give you 8 out of 10. Thank you.
Thank you,
Okay.
sir.
We will stop here, guys. Obed, I assign tasks before you come. I give everyone task, okay? So anyway, we will stop here. Inshallah, next session will be teaching ECG and ABG and X-rays. Okay, guys?
Okay, sir.
In
Okay.
the previous 3 exams, they are giving them X-ray teaching, like for example, shoulder or knee or elbow or any. So we will do all expected X-ray teaching in the exams. Okay?
Okay.
Thank you,
Thank
guys.
you.
Bye bye.
Thank you, sir. Bye.
Thank
Thank
you.
you.